a spiel, which is really long. I normally have to read out at these times, but basically to summarise, this meeting is being recorded. Gemma, I think, starts the recording now, and that will be put on the publicly available website later. So if you, well, just be aware of that, I think. I'll ask everyone, because Teams sort of sucks up internet and causes problems. If people can have their sadly have their images, their cameras switched off unless they're speaking, and also if you remain mute until you speak. Can I ask, I'll try to keep an eye, it's quite difficult to keep an eye on who's indicating, but if you could indicate in the chat, ideally, if you wish to speak on an item, that would be perfect. Is there anything I've missed out, Gemma? I think that covers most of it, doesn't it?
Yes, I think so. I think that's fine.
Good. Yes. Okay. Right. Okay. Let's kick off. Start off with apologies. I've already had Liz Terry needs to leave for a meeting at 3:30. Katie Summers needs to leave at 3. Esther Blake by 4. So we're going to bring up the children's safeguarding report a few items further up. I've got Jason
Brock as well.
Yeah, so Jason Brock, who Councillor Jason Brock is off doing Politics South down in Southampton, which sounds a bit of a faff, have to go there to Southampton, but it might be quite a fun time to do Politics South, I think, this weekend. Well, for Jason anyway. Do you have any other apologies? No? Okay.
None from me, Chair. Gemma.
Okay, so welcome everyone to the meeting. I'm Graham Hoskin, Chair of the Board. The other thing I should have said is when you do speak, if you could introduce yourself for the first time, so there's lots and lots of people on either in the meeting or here, so people won't necessarily know who everyone is and take forever to do introductions. So if you could introduce yourself when you speak. And the other thing, if you are speaking, I'll remind people as they do their reports, but a general rule is assume that people have read the report and also then introduce the highlights and things you want to particularly bring people's attention to. Okay, so we've had the apologies, declarations of interest. Has anyone got any declarations of interest on the agenda they need to declare? I'm not seeing anybody indicate. If something occurs to you as the meeting moves on and you realise you do have a declaration of interest to make, then also you can do that at the time. But obviously that was the moment. Minutes of the last meeting, pages 5 to 80. I'm not going to go through page by page. Has anyone got any points of accuracy they want to raise? Or any matters arising that they want to raise from those minutes? Not seeing anyone indicate, in which case we'll sign those off as a true record, and then move on to questions. We do have a question. I think it's Mr. Francis Brown asking on behalf of Mr. Tom Lake. Hello, Francis.
Hello. Yes. And
I'm going to ask, as it's specifically around primary care, and Andy Czerski is my vice chair of this board, and a particular, expertise in this area. I'm going to ask him to answer the question. So, Francis, fire away.
Okay. Anecdotal evidence indicates that some patients are still finding great difficulty in obtaining GP appointments. Patients on certain continuing medications are periodically asked to attend a medication review appointment. However, some are finding that they either cannot get through by phone to their surgery at all, or have to wait several weeks for such an appointment, during which time their medication is exhausted. The system of medication reviews is intended to reduce risk to patients. However, if it entails long delays or complete abandonment of the medication, the risks to the patient may well be increased. How can this paradoxical situation be sensibly resolved?
Thank you, Francis. So Andy Czerski, GP in Caversham, Clinical Director in Caversham of the PCN, and Vice Chair of the Health and Wellbeing Board. So on behalf of the Chair, I'll do the response. So no medication should stop just because a medication review has been missed at the expected date. The annual review is guidance of good practice, not a stop or go for medication being issued. Frequently, pharmacies will advise patients their medication review is due, and this can cause patients a lot of stress that it has to be done, otherwise the medication cannot be issued. That is poor information. The patient then gets stressed they cannot get an appointment in time. Can I reassure that the medication is not stopped because the medication review date has passed? Some long-term medications need an annual review for blood tests to ensure safe ongoing prescribing. Some blood testing may have slipped in the past year during the COVID pandemic due to reduced capacity of blood taking appointments. And more recently, in August and September of 2021, they were delayed due to blood bottle shortages. GPs have still prioritised bloods in those patients that need them, especially our diabetic patients, and all of general practice is working to catch up with these blood tests. Many medication reviews can be done online via request on the practice website, sometimes via text messaging or by phone, and they can be done by a clinical pharmacist, not just a GP. That's the end of my answer.
Great, thank you. Mr. Brown, do you have a supplementary?
Yes, I'm hearing actually even today that some patients are going to their pharmacies because they can't get through to their surgery, and the pharmacist, the community pharmacist, is emailing in order to get things moving again. They don't get paid for this, as far as I understand it, through the community pharmacy consultation service. So this is very hard on the pharmacist and very stressful for the patients. Can I invite a comment, please?
Yeah, I mean, community pharmacists do offer medication reviews, and as part of their service, and if there is something that they want to highlight to the GP in terms of how the patient is taking their medication, or something that maybe not taking anymore as part of their regular medications, then that comes in a report back to the GPs. So actually community pharmacists can assist in the medication review process, and then we can update the patient's record and say that the medication review has been done that way. If they email us because they're trying to get things moving, I'm not quite sure what that's about, because they can still request the prescriptions as normal. We don't stop them from the GP end. And like I was saying earlier, that no medications which are on a repeat prescription are stopped because the patient haven't had a medication review. They are on the repeat list and they are ongoing for that reason. That's why they're on the repeat list. So yeah, I think it's maybe a communication thing or a misconception that the medication review is somehow, you know, it has to be done at a certain time. The date of the medication review is guidance. Like I say, the medication should not be stopped unless the GP has specifically said to stop it.
Thank you.
Hope that helps.
Thank you. We'll investigate further. But thank you for the response. Appreciate it.
Thank you, Francis, for your questions. Always good to see you at the board. Thank you.
Thank you.
Right. I do not believe we have any petitions.
No petitions,
so,
Chair.
That's good. I was able to know about any. In fact, so we'll then move on to item number 5, which is pages 19 to 38 in your agenda, and that's basically an update on COVID-19. And Becky, a lot has happened in the last couple of days, hasn't it? So I'm not sure how far your presentation can be able to reflect that. But anyway, I'm going to hand over to yourself.
Yeah, so I'm Becky Pollard. I'm interim public health consultant at Reading Borough Council, and you're quite right, Chair. As ever with COVID, things move very rapidly. So the reports that I submitted giving an update in terms of case rates and the surveillance is of course now a little bit lagging with the latest data. So instead of going through all the slides, I just wanted to update the key messages for the board. So we did see a big rise in cases before Christmas, New Year. That has come down now. So our rates in Reading are now 1,206, which is obviously different from what's in the report. But we are now higher than our neighbours, the South East and England. But very pleased to see the case rates in the over 60s has dropped. But we're still seeing highest case rates in young adults, ages 22 to 39. But of course, I'm sure the board members will know we are seeing a rise in cases in primary school children specifically. So we're keeping close eye on that and working very closely with schools on how to manage those outbreaks, the situation, to what controls can be put in place. In terms of mortality, pleased to say that we've had no deaths related to COVID since mid-December. And currently there are 82 patients in the Royal Berkshire Hospital with COVID. That has increased slightly, but it is stable. It's not going up, which is good news. And just to confirm, pretty much all the cases we're seeing is Omicron variant. And just finally to say, in terms of surveillance, flu rates also remain very low, which is good news, but we know that there is pressure on the hospital, winter pressures. So I think there is still a lot of pressure on the acutes. And as you say, in terms of changing policy, just to highlight a few things, you'll be aware that self-isolation is still mandatory for 10 days, but if people test negative on day 5 and 6 and have no symptoms, they can come out of self-isolation. Face coverings no longer compulsory for secondary school classes. Working from home no longer a requirement. Along with COVID passes, and we're beginning to see restrictions to care homes eased. But as you're all aware, we're still waiting for updated guidance on a number of those issues. But I would just highlight to the board, and I'm sure Deborah will concur with this, we are seeing a lot of pressure on schools with rising cases, and we're doing a lot of work with heads on how to manage those outbreaks. So I think that's really all I wanted to say, Chair, just to update the data. We can send updated surveillance figures around, but because it's so fast moving, what we sent round is now a little bit out of date.
Thank you. Thanks for that. I'm going to, because it is very different, I'm going to take any questions or any points anybody wants to raise on that section before we go on to vaccination, if that's okay. So if you've got any questions or thoughts about vaccinations, hold that to the next section. I've got Dr. Jachersky indicating.
Yes, thank you, Chair. Becky, just a quick clarification about face masks, because I think there was talk about easing that generally, but I think there was still advice to wear them in enclosed areas. I just wanted to check also, I didn't see that they specified in healthcare places. Did they say that you should wear coverings, or was it also going to become advised? Because I think general practitioners would still be rather twitchy to relinquish that rule in practices, and I'm sure the hospital would want to enforce face coverings in the hospital as well. Thank you.
Yes, my understanding, the face coverings for the sort of general population is being eased, but the recommendation, if you're crowded in enclosed spaces, it's good practice, but it won't be mandatory for secondary school classes or on public transport. As far as I'm aware, face coverings in healthcare settings remains, but again, a lot of this, the guidance plays catch up with what we hear on the news, but I would imagine in terms of infection control, that's still a really important point, because dealing with clinically vulnerable patients as well.
Thank you very much.
Thank you. I can't see anyone else indicating at the moment. I do have, well, I have a point and a question. So, yeah, it's hard to sort of get our heads around the sudden relaxation of a lot of control measures when cases are still very high. So, just that is something is quite hard to digest. I think certainly around masks, which the evidence is quite strong in terms of reducing infection rates. So I find that quite alarming. So the question I have around is around schools, where I know that my kids broke up for school just before, just as Omicron was starting to get going, and they're now going back. And there's cases all over the place. Kids have been sent home, and I worry that some of this is going under the radar because of the change to the testing arrangements. If you have a lateral flow positive, you don't go and get a PCR, and some of the symptom update app things might not see kids quite so much. And I'm really alarmed by the Secretary of State for Education, as I think is in today's media, saying that he would actually instruct schools that they shouldn't have masks in the classroom or in settings, which seems alarming to me. And I didn't realise he had those powers. I guess he does. And I just wondered, obviously, if there are outbreaks, I know there's outbreaks in my youngest daughter's school at the moment, and therefore relaxing the mask mandate seems really alarming. I was wondering what powers we've got, or what how we can work with schools so they have the, so that they can, so that I suppose teachers and school leaders are able to take some sort of control rather than the Secretary of State for Education, who may have a different political reason for trying to remove the mask mandate, when actually what's important is what's right for the Reading schools.
Yeah, absolutely. I'll make a comment, and Deborah, you might want to also comment. The current guidance is that if there's an outbreak in a school, then the school takes appropriate measures, reports the cases. They have a toolbox of interventions they can employ to deal with that. And I know many schools and many heads are instructing staff and students to continue to wear face masks. That does seem to be against what the Department of Education are saying. And obviously we're working very closely with individual schools to risk assess. They do a risk assessment, and if it's felt that that's an important additional measure, then I think, we would support the schools, because it's not only about the students, it's about the staff and the capacity of the staff to keep the school, open. So I think it is a very complex picture. And I think, we're still awaiting a clearer instruction from the Department of Education to what this actually means in practice. But Deborah, you might want to comment as well.
Yes, good afternoon, everybody. I'm Deborah Glassbrook, and the Executive Director of Children's Services here in the Council on Brighter Futures for Children, and have the delight of being able to support the schools during this really tricky time. And I suppose I'm just going to echo what Becky said. I think the schools have done really extraordinarily well during this last nearly 2 years. And what we've supported them to do is absolutely to manage the school, the learning opportunities for the children in a safe and positive way. And so what we'd want them to do is to continue to do that and make the individual decisions they need to make for their school and their school safety. And whilst it's of course incredibly important that they follow what other advice there is, I think what we know is the way that it has been managed has been so positive, with the high levels of attainment that they've continued to have, the positive outcomes for so many children, albeit understanding some children have been disenfranchised, of course, during this difficult place. I would want to encourage them to continue to make those right decisions on a risk assessment basis for the individual school and the individual children there. So that's what we've done all the way through, and we'll continue to do that. I hope that's helpful.
Great, thank you, Deborah. I mean, personally, I completely and wholeheartedly support that. Supporting schools to make decisions right for them rather than necessarily what the Secretary of State suggests. Tracy Dashkovich, you've come on the screen. I don't know if you wanted to speak.
For some reason my hand won't work. I'll go.
Okay. Oh, it's working now.
Yeah, I mean, Deborah actually said it all in terms of the brilliant job that the school has done, and we've had some conversations that have come through, not necessarily from our local area, but that is feeding through in other areas where schools, if you've just described it, Graham, are getting a very clear directive through the Secretary of State that masks must not be worn. And it is being almost discouraged. I mean, I haven't heard language as strong as that locally. And like Deborah and Becky have already described, our schools have been incredible. And what I would say on that, if we do get that directive, and if any school is at all concerned that they are being forced down a route that they don't feel is safe for the population of their school, then there are statutory powers that I hold that can override the decision of the Secretary of State for Education to keep our schools safe. So if we do need to go route, there is that. But I mean, our schools work in such a collaborative way anyway. I think we will come to a local decision quite easily amongst ourselves. And I haven't heard locally about that directive being forced on us. But if it should be there, then there are things that we can do to overcome that.
Great, thank you. So I don't know if I should have introduced you, Tracy Dashkovich, you're our Director of Public Health for Berkshire West.
Yeah, indeed, I should have done that, shouldn't I? So I'm on week 8. It's very good to be here. Thank you very much.
Welcome. Great. Well, thank you much for those answers. Those were definitely. I mean, we hadn't discussed this before the meeting, so they're very much the answers I was hoping you'd give me to that question. So that's great. Nobody else indicating. So thank you very much, Becky. As I say, we'll have to digest the rapidly changing situation where it comes to controls and see what impact that has on the course of the pandemic in Reading. Okay, should we move on to the vaccination programme update? Katie, is that you?
Yes, thank you, Councillor Hoskins. I'm Katie Summers. I'm the Director of Place Partnership at Berkshire West Clinical Commissioning Group, and I'm the overarching vaccination lead in Berkshire West. So just to give you some highlights, we still remain to have within the report, as described, just over 48,000 people who are still left to be unvaccinated. Majority of those people are from the younger population, 18 to 39. It's fair to say we have now changed some of our approach, I would actually say, because we're moving away from very much a pandemic approach now into very much about supporting those people who still remain to be unvaccinated, as well as catching up for those people who have boosters. We are concentrating now on how we can get, especially from the point of view of the most deprived areas, as well as also those people that are seldom heard, so from different cultures, how we can actually ensure that we build up their vaccine confidence and able for them to come forward. Our PCNs have done a huge amount of work, and we double checked that with them this week about what they've been doing to encourage those people to come forward. Individual GPs have been trying to contact those individuals between 6 and 8 times during the actual pandemic, and lots of people still aren't coming forward. So with that, we've now agreed that we are going to take a very much engagement approach. It is a thanks here to the council and the comms lead. They're now working really, really closely now with the actual CCG comms. We're going to target now comms messages to different cohorts, and the lead up to then actually having those people come forward and actually be vaccinated. We are going to start forward with the Health on the Move van. We have also started again with vaccinating for second doses for the 12 to 15-year-old programmes. And equally, we are going to be going again for immunosuppressed. We've got the information through from all GPs that they have got their plans to make sure the immunosuppressed are supported with regards to their 4th dose. The final thing I'd want to actually highlight here is that the 5 to 11-year-olds who are extremely clinically vulnerable will also start to be vaccinated very shortly. We're waiting for guidance about what's happening with the actual vaccine for that, but actually I'm sure the individual GPs will be in contact with those children that are extremely clinically vulnerable very soon. We had a really good conversation with the school's immunisation team yesterday, and they are also going to help with those individuals, especially those people that are in special needs, and offer to do their actual children in those special needs schools, because actually they might feel that would be a safer place to do it in. The final thing I'd want to recognise here is the team here have done a huge amount of work. We have, though, recently heard that actually there is much more of a risk at the moment from anti-vax campaigners, especially over this weekend. This is linked to the World-wide Freedom Day, so I must admit each council have done fantastic pieces of work here to support different sites, to help them with any forms of walking the streets where those sites are, to help with any campaigners that might be around and build up the confidence of people coming through. So I think that's a bit of a quick summary for you, Councillor Hoskin. Happy to receive any questions.
Thank you. Thanks for that. I don't really need to go into it now. I mean, obviously there's a number of different projects and ideas being looked at in terms of increasing the uptake. I would just like, I mean, no one's indicating at the moment. I was pleasantly surprised by the 24% of the 12 plus unvaccinated. May seem a lot, but actually it's probably better than I thought it was. I don't know what that's like compared to what that's like from a sort of national scale. I presume a significant number of those, maybe like my eldest daughter who's now missed it. She's actually got COVID twice in October and January, and so has not been able to be vaccinated. So I suppose one thing, maybe not for you to answer, but we need to consider is how we get the message through to people that may have been in that situation. We're getting kids that have been getting, COVID over that period and therefore get picked up again, say in springtime.
That's already in plan, and actually the comms leads are also ensuring that there is a programme of work to inform the local populations that actually if you've had COVID, that doesn't necessarily mean that now you are protected. You still need to get the vaccine. So the comms leads are working on a joint message in order to support that, and that will be targeted into both schools as well as the general population.
Great, thank you. I mean, I think as we move into the year and the virus remains very much part of our lives, but less visibly, the kind of mechanisms to suppress it are less visible. I think we may well need to think about how we change those messaging about really encouraging people to be vaccinated or get their boosters. And that's, I suspect we'll have to amend, our messaging and how we work in the coming year. But thank you for that. Anyone else have any questions, any points they want to raise? Nope. Okay. In which case, thank you very much, Katie. We've got the Brighter Futures for Children COVID update. Deborah, are you leading on this?
Yeah, yes, indeed, I am, Councillor Hoskins. Thank you very much, and good afternoon again to colleagues. There's just a few slides that you have in your pack there. I think we've covered actually a lot of the things that I wanted to say in relation to the issues around COVID in schools. I mean, I think, what's been really difficult for us, for our teachers and all of their staff, is a lot of the changing expectations to manage it, and trying to keep up with what often is daily guidance has been really tricky for them, and they've done a remarkable job, with some frustrations, I might say, and but ongoing support. We do still have a fortnightly briefing with all of the head teachers invited to come. We put that into place last March. We've continued with that, and we're delighted that colleagues from Public Health, as we've said, have been supporting that. I think the number of notifications that are coming through from schools is still really quite extraordinary. I've had about another 25 just today, just to let me know what's happening in the schools. And we have reached the stage where a couple of our schools have had to close for a matter of few days because they've just not had enough staff to keep going. So, quite a serious situation that we're supporting them in with there. And as a result of that, as you can imagine, there is a worry amongst all of us about the children, young people being disenfranchised from school, the ongoing impact that has then potentially on their mental health, them falling behind in terms of their attainment. And there's quite a lot of research that's showing just how far behind some of our children going with a range of sort of You know, somebody talking about 115 days lost for some of our children, and the particular impact on the most vulnerable and disadvantaged children that we're very aware of, and looking at some of the additional support we can give those children particularly. So, you know, very much aware of that in terms of the schools. Going on to thinking about social care and the social work world, I've reported here to you all before that we've seen increased complexity of the work and therefore the challenges for staff. And it's quite interesting that some colleagues are saying, well, what does it mean by complexities? And I think, you know, what we're seeing is families who have been really impacted, again, those who've got the disadvantage, the more vulnerable, who are not out and about again in society in the way they were, not having some of the protective factors that we have already set up in our communities, in our systems, really seeing some very embedded abuse and harm going on. And so, you know, when those situations are referred to us, we're not able to deal with those at the earliest help. They are some very significant, as I say, some very complex work that's going on, and that's continued, and we anticipate that that will continue as, you know, over the next number of years, and goodness knows at this point we don't know for how long, but we're continuing to see that, with the key demands around poverty, family dysfunction and mental health, not only of the children, as I've just said, but really of the adults as well. So we continue, of course, to work across the whole system, working with colleagues to address those issues. We've got some continued challenges in securing local placements. I think it's difficult maybe to see a direct correlation with COVID in terms of what does it mean in terms of local placements. But as you can imagine, providers, like the rest of us, some of them have had staff shortages, foster carers who've not been willing to take more children at a particular time because they themselves have been worried about COVID, or indeed have been, you know, suffering with COVID themselves. And then the other complicating factor attached to that is that our unaccompanied asylum seeking young people, and apologies for members on the board today who don't recognise that short form. I know it's always very frustrating to have a short form, but unaccompanied asylum seeking young people has moved to a mandatory approach. So until earlier, well, this year, the situation was that in Reading we are anticipated to take a 0.07% of our children population, which is actually 26 young people, to come and live for those children who've arrived usually on the small boat route from different places overseas, and we have now got 24 of those young people. It's made more difficult because it is now mandatory that we take those children, young people. We were doing incredibly well in Reading taking them anyway, but as you can imagine, again, during COVID, thinking about their education, looking after them, making sure their health needs and finding local places have again been an additional a challenge for us, but one that we have addressed very positively. And, you know, we're proud to be able to say that the young people that we have get a very warm welcome and are very well supported. So my third and last slide is really just to let you know about the early help and prevention. Again, we've mentioned this before, but it's ongoing, where we've got our 0 to 2-year-olds who are still not experiencing the same levels of socialisation that they've had in the past, and the impact of that when they're actually turning up at nurseries or in childminders, you know, really showing that they're quite behind in knowing how to interact, how to behave, how to learn and everything. So again, we're addressing that, but it's just a really important thing for us to notice and to be aware of. Serious youth violence, very sadly, we know in Reading that we had some very upsetting and tragic outcomes to some the youth violence that happened last year. We've had the outcome of the trials in relation to both of those murders that took place in January and February last year, and we're aware that youth violence is on the rise, and we're really concerned about that. And as part of the Berkshire West Safeguarding Children Partnership, we've been doing a big piece of work looking at the impact of that and what we can learn from youth violence that's been going on in this last year particularly, and we'll be able to report on that in the not too distant future. In terms of the Education Welfare Service, well, they've been impacted again by COVID, by the work that they're doing with the schools. We did provide support to the schools through the Education Welfare Service to make sure we could pick those children up at the earliest possible time we're continuing to do that with the Education Welfare Service. And then just a couple of projects for you to know about that we've put into schools to provide support to the schools and to the hospital in terms of identifying those children who may be disenfranchised, who may be really struggling to cope during these really difficult times. We've got some family support workers in there to provide some additional support and identify what work and support we can put those families to prevent any greater impact and situations escalating. So although that might sound a little bit stark in terms of some of the impact it's having, I think it's really important we know that, and I think what Becky said is really important. We're moving out, it would seem, out of some of this, but I think the impact for our children and our young people and their families is going to be felt for a number of years to come, and so we're very keen to continue to work with everybody in partnership to make sure we can provide the very, very best services. Thank you very much.
Great, thank you, Deborah. So any questions, any points anyone wants to raise? I did have a question. You kind of addressed some of it, but I was really interested in the 0 to 2-year-olds and not experienced socialisation. I just imagine what that would have been like for my kids at that age. Do you think this is something that will be an area of a cohort that will need to provide some additional support for some years to come, as opposed to sit them all together for a little bit? I imagine that it's going to be quite a complex and more long-term issue. I don't know what your views on that.
Yes, I mean, I think that's absolutely right. I think it has been an issue now because, of course, those children who were born back 2 years ago are now coming up to, but we've had children then born through that period of time. I mean, we're delighted that the council have given us some additional money to work with that particular group from Brighter Futures for Children, particularly focusing on working with those 0 to 2-year-olds. We really need to help parents understand what's been missing, especially those first-time children, of course. Those who've got siblings may not have been impacted quite as badly, but if you're the only child and the first child, the impact, of course, is going to be much greater. So, of course, we are going to need to keep a focus on those and look at what we need to be able to do to provide the support, especially when we're looking at things like school readiness, socialisation, opportunities for them. So it is something that's a key focus, and we'll be able to report back on some of the impact of the work that we're doing in that area. Thank you.
Great. Thank you, Deborah. Steve Raffield, you've come up on my screen.
Yeah,
was that intentional?
Yeah, thank you, Councillor. No, I was just going to, not so much a question, just add my support to Deborah, really. I mean, clearly violence involving our youths is something that I'm also very concerned about. Deborah and I have spoken about that, and I think, for us, identifying a cohort of children that we're most worried about and making sure that we not only deal with kind of criminal justice outcomes, which is primarily the job of the police, but also look at how we can signpost some of the riskiest kids towards intervention and support is really, really important. So just to say, well and truly on my radar as the new commander at Reading. And I should have introduced myself for everybody else. The new commander at Reading, Steve Raffield. Thank you.
Great, thank you. Okay, I've got a couple of people indicate. Oh, sorry, Deborah, did you want to respond to that?
No, sorry.
Okay, I've got Councillor Alice Mpufo-Coles.
Hi, thanks, Deborah, for your detailed update. Thank you, Chair. I just wanted to find out, even from the inspector, if they are aware of a group here called Mothers Union in Reading about the knife crime that they've started to help in the sense to collaborate with them so that they can identify and help in the sense of knife crime. They had a meeting yesterday, I think yesterday, on Zoom, and they are doing local and grassroots work. So if you are aware of that, are you aware of this group?
No.
No, I have to, sorry, what was the name of the group again?
It's an affiliation to what is called Mothers Union, which started in London, which is spread all over the country, and they have started one group last year when there was the meeting at MAP and everybody came. I think some of your the policemen came, and then they started what is called Mothers Union, which is about against crime knife. And I think it's very important. I'll probably email Deborah and give him, and you, Steve, also to get in touch with them and attend the meetings and how we can collaborate to work together.
Yeah, perfect. Thank you. That'd be
Absolutely.
Really good.
And we'd be delighted to do that. So thank you very much for alerting us to that. That'd be very helpful. Thank you.
Great. Thank you. Thank you very much for that, Alice. And then I've got Katie Summers indicating.
Yeah, thank you so much, Deborah, and thank you, Councillor Hosking. I'm just wondering, we've got an opportunity in the fact that we're about to do that vaccinations of the 5 to 11-year-olds. Granted, it's not in that 0 to 2-year-olds, but you'd like to think actually some of the parents might be actually had babies in that time. I'm just wondering, Deborah, if there's an opportunity for the individual PCNs and also the SAS team who would be doing this, if we could work with you to identify some form of criteria whereby they could be looking at when they're doing the vaccinations, having a brief assessment about what's actually happening with that child as well as those parents, whereby they could be identifying anybody at risk, and then obviously those could be then supplied to you as somebody who might need to be flagged as such. Is that something we want to take offline?
Well, I think we could, let's take that offline, Katie, because I think there's something about perhaps sharing information at that point as opposed to by doing an assessment. But yes, let's take it offline, and thank you for the opportunity to work with you on that and your support you're offering there. Thank you.
Thank you.
Great, thank you. I haven't got anyone else indicating, so thank you very much, Deborah. For that,
thank you very much.
Overview. Okay, right. So let's move on to the next item, which is item number 6, which is Health Watch's report on Reading people's experience of the Berkshire West Urgent Community Response Team. That's pages 39 to 60 of your agenda reports pack. Do we have Mandeep Bay? Yes.
I've got a presentation which I hope I can share if possible. Oh, no, my screen's frozen. Ah, okay, sorry, I'm back.
It's okay.
If I can find the right. Can you see that?
I can't yet. I don't know if anyone else can.
Can't yet, Mandeep.
Okay, maybe Gemma, could you help me with this?
Yeah, if you give me a moment, I'll just load the presentation.
Apologies for the delay.
No problem. It's a moment to get yourselves a drink or stretch your legs. It won't be long because the presentation's coming up.
Thank you. Oh.
Can anybody see the presentation?
Yes, I can see it now. If we could just start the slideshow. Thank you, Gemma.
Okay, bear with me. Is that okay?
Yes, that's perfect. Thank you. If you could just flip to the first slide, that'd be great. So Berkshire Healthcare Foundation Trust worked with Healthwatch Reading and our partners in Woking and West Berkshire to gather feedback on the Urgent Community Response Service. And for those who are unfamiliar with the Urgent Community Response Service, it's a service that aims to prevent unplanned hospital admissions by sending a team to people's own homes within 2 hours of a referral for a crisis, such as a fall, injury or deterioration in health, or within 2 days as part of a reablement response. We worked with Berkshire Healthcare Foundation Trust to agree a protocol and conducted interviews with 20 service users. We use these questions as a baseline. Thank you, Gemma. Could you flip to the next slide? And as I mentioned, we conducted 20 interviews, but we actually spoke to over 40 people. And some of those people who didn't take part in the interview were either too unwell, were confused, or simply didn't not want to take part in this sort of process. In most cases, we spoke to the patients themselves. In other cases where the patient was too unwell or too vulnerable, we spoke to their relatives. The vast majority of people we spoke to were over 65, and I think the oldest person we spoke to was 96. Can I have the next slide, please? So we wanted to understand if people were receiving a timely response. And what we found was a large number of people were unable to tell us how soon after their referral that the service actually arrived in their home. This speaks a lot to the vulnerability of the service users. Others recalled that they arrived promptly, quickly, and made a point of saying they were really pleased with that. One of the things we learned while asking this question was, this is often the perception of the service user, because a lot of the people we interviewed receive a variety of services and found it hard to differentiate between some of the services they received. Sorry, next slide. So we wanted to understand what support people thought they would get from a service like this. And actually, this was just a really difficult question for nearly all people to answer. And we made two main conclusions from this. Awareness of the urgent community response service is quite low, and very few people understood what the service was for, although they were always grateful for the help that they received. And in addition, sorry, next slide, we wanted to understand more by asking them what happened during that service. What sort of support were they receiving? And some of them gave quite a good account of the things that people were supporting them with. These are their direct quotes. And most of the time when we were asking what happened during the service, it's mostly the relatives that were able to give us fuller accounts. The service users themselves weren't in every case able to give a full account of what sort of interventions happened at the time. Next slide, please. Finally, we asked service users about the quality of care they received, and the vast majority had nothing but praise for the service. They talked about being listened to by the professionals that were coming into their homes, having things explained to them, the caring nature, their professionalism, and how helpful they thought they were. Sorry, next slide would be great. And I could have filled 4 or 5 slides with the wonderful comments that people left for those professionals. However, this project also raised a number of concerns from speaking to these service users, and concerns for the system as a whole. This is not just about the urgent community response service. And the first concern that we all received was about the vulnerability of the service users themselves. And on the right there, there's a short case study, and within the report itself, if you've had a chance to have a look at it, there are a number of case studies which highlight the vulnerability of the individuals that the urgent community response service is supporting. So many of the people we spoke to were confused, emotionally and physically fragile. They often couldn't identify the service between the number of different people coming into their homes, and they essentially are passive recipients of care, even though they were always grateful for all the support that they received. The second concern it raised with us was around prevention. Nearly half the people we spoke to had received support from the service after a fall. This raised a number of questions for us. Could those falls have been prevented? Are people receiving adequate and timely care, or timely assessments of their care? And are we missing anyone? The third point that we learned through this process was the handover of the service and integration with other services. A lot of the family members we spoke to in particular raised concerns about what would happen next, who would support them next. And this was even more so in cases where the person they were caring for their relative was getting increasingly fragile. This then in turn raised another query about the support they were getting as unpaid carers. Not only were they tired, they were confused about what was happening next and about what would happen in the future with their relative. Overall, the service is valued amongst service users greatly, but the system can work better together to support those really vulnerable individuals. And I would say that was one of the greatest bits of learning we took from this report. I'm going to leave my short presentation there and happy to take any questions.
Great, thank you. Thank you very much for that, Mandy. Yeah, any questions, any points people want to raise? It's, do we have, I wasn't quite sure, did we have there's responses to the report from Berkshire West, sorry, not Berkshire West, Berkshire Healthcare Foundation Trust?
Yes, we did. Yes, we did. The responses are included, and actually one of the things Berkshire Healthcare Foundation Trust has done as immediate action is they're producing things that they can leave in people's homes, which give the contact number for the service. So that was an immediate action, and then now I'll let I'm sure Berkshire Healthcare colleagues are on the line, so I'll stop there.
Okay, thank you. Yeah, I wasn't quite sure. So is that Catherine? Sorry, I'm trying to find people on this list. Is that Catherine McDermott? Are you from Berkshire Healthcare?
I am. Thank you very much.
Yeah, I don't know if it was worth having the response. I mean, it's quite a positive response, isn't it, to a positive report, and then we can take questions from that point, if that was the best way to handle it. Thank you.
Yeah.
Catherine.
So thank you, Councillor Hoskin. We were really fortunate, actually. Mandeep was able to come along. Sorry, I'll stop. I'll introduce myself first. I forgot to do that. Sorry. I'm Catherine McDermott. I'm the Director of Strategic Planning for Berkshire Healthcare Trust, but I'm also the Exec Director for the BOB, the Buckinghamshire, Oxfordshire and Berks West Ageing Well programme. So I have hopefully quite a good overview of the whole of the programme. We were really fortunate. We had the BOB Ageing Well programme board just last week, and Mandeep and colleagues were able to come along and they presented the report to the programme boards, which was really valuable and really well received. So we have had the opportunity to think through the implications of the recommendations. So we felt it was a really excellent report. I think Healthwatch themselves felt that it was had been a really positive exercise. Communications was one of the things that we took from the report, and we have had a gap in our comms support, which has now been plugged. So we wanted to work with Healthwatch going forward around the best ways to improve the communications with patients. So that's a piece of work that we've taken forward. We also want to have a look at how we integrate our urgent care services with our wider community services. So as you can imagine, most of the people that are in receipt of an urgent community response service are actually known to other services as well. So there is something about communication between the services about the patients and the patient notes. So in summary, we received the report last week, very positive, and we've got a number of actions that we'd like to take forward with Healthwatch around improving the communications to patients, and a number of actions that we've taken on board ourselves around how we make sure information is shared across our services. So yeah, thank you very much for allowing us to respond. And Mandeep, thank you very much again for your wonderful presentation. Happy to take any questions. Thank you.
Great, thank you. I'll wait to see if anybody is this point questions and any points anybody has. I do have one question, not necessarily within the scope of the review, but I'm going to put it out there. In terms of this project, obviously there's a lot of really positive feedback from people that have received the service. In terms of the overall aim to be reducing pressure, reducing the need for people to go into hospital, do we have anything? Well, I suppose my question would be: is what we're seeing justification for further investment in this service in order to reduce pressures, particularly in the at the hospital stage? Is it something that's worth investing in order to save money for the overall system?
So I mean, I have an answer to the question, but it's not a straightforward answer, I'm afraid. So I think the service has proved itself to be invaluable in being able to provide a rapid response. But there is something about the fact that it's a 2-hour response. It may actually be appropriate for somebody to have a response within 4 hours or 6 hours or just the same day. There is more that the 2-hour response service could do in terms of taking referrals from places like 111 and SCAS and possibly self-referral. So there is capacity to take on more. However, I think the answer to the question lies more in preventing people going into crisis in the first place. So the Ageing Well programme, it will include, we're still waiting for the guidance to come out, but anticipatory care planning. And I think that's going to be really important in terms of working with our GP colleagues and with yourselves as local authorities, and really preventing the case study you gave and the question Mandeep posed about, you know, the numbers of people have fallen. What could we be doing to prevent that actually happening in the first place? So I'd say yes, the crisis response is an important service, but actually really we should be working together to prevent people getting into crisis in the first place. And I think that would be a real, you know, where I'd really want to try and focus some of the work going forward.
Okay, thank you. Thanks for that. I've got Andy Czerski indicating. Andy.
Yes, thank you, Mandeep, for the report. I sit in Urgent Care Board, and we often get the figures from the Urgent Community Response Programme on the number of referrals they have and how quickly they see them, but we don't get that narrative of what the patient experiences. So I thank you very much for the report, because I think that definitely shows that it is a valued service, and the clients who are referred to it appreciate it absolutely. And as Catherine knows, as a GP, there was frustration about patients we refer, they can't get seen in 2 hours, or they don't quite fit the criteria for 2 hours, but they are going, the GP can see they're tipping over, there's a problem. And so we've worked together to try and get the 2-day response to be put in place and have the capacity for that. So if we've got family pulling out all the stops to look after a loved one for a day or two, but they do need that extra support coming in, then that 2-day response then kicks in to keep that patient who maybe has had a fall or has lost confidence or has got a minor illness which is making them tip over. And if they didn't have that extra support and care at home, they would go into hospital. And that's sometimes the dilemma GPs have with those very frail, you said vulnerable clients, that there's 2 options. Either they stay functional at home or they go to hospital. Well, this is the in-between that keeps them at home, stops them being deconditioned once they hit a hospital bed and don't move at all for 10 days and hopefully come out, but sometimes they don't. But if they stay in their own home, there's more chance for them to recover, and then they're in the familiar surroundings. So those vulnerable patients are, one could argue, they should be in hospital, but versus actually they are better being looked after at home because they recover more efficiently at home. And that's always a dilemma we always have. And some patients, and Catherine will have the figures, that have response but then end up in hospital, but anyway, but actually the vast majority do successfully stay at home and do successfully recover. So yeah, I mean, just saying it can be a complex picture, but it's useful. Thank you very much for your report to actually show the patient's experience and highlight some of the challenges that we still have. This service is still growing, as Catherine what hasn't said is that there's still issues with staffing to make sure the services as there's more scope and more capacity potentially growing in the service. It's because it's still growing, and hopefully as it grows more, it'll see more clients and it will be more successful and give better results to our patients. Thank you very much.
Great, thank you. I haven't seen anyone else.
Graham, can I just make a comment?
Yeah, no, I was about to ask Mandy if you'd like to either come back or come back on any of the comments. Mandy.
Some of the people we spoke to or tried to get hold of, in the time we made an appointment, they'd actually gone back into hospital, and some of them were getting on very, very well at home with the support of this service. I think one of the other takeaways that I would take from this report is we do, and we hear this all the time, especially when we talk about COVID, the people who are in their homes are so vulnerable. They are so vulnerable, so frail, and they are increasing in acuity. And we need to be looking to provide them with timely responses actually for their own well-being, not only just to stay at home for their general well-being, because we know services are under pressure, but there are a lot of vulnerable, frail people at home that really do need timely support. I think that's one of the big things we learned from this survey.
Okay, thank you, Mandeep. And yeah, no, it's really enlightening survey as well, actually, in terms of the, as I say, sort of 2 things. One, about really great service that you could see develop in different ways, but also, you know, as has been said, the need for further preventative work, and you know, the great deal of support that is required in very different ways with different people across the town. I've got Katie Summers indicating. Katie.
Thank you, Councillor Hoskin. I'm just wondering, Mandeep, are you tied into the Reading network, Action Network group? It's one that Councillor Hoskins has put me in contact with, and this is where the Reading is a group that, Thank you, Councillor Hoskin. And actually, I think that's a group of volunteers and voluntary sector, and actually they're really quite keen of actually supporting local people, especially as part of that COVID piece, and linking them up with different services. So Mandeep, shall we take that offline, and if I put you in contact with Richard, I think that might actually help discuss and also support those local residents with any concerns that they may have, and link them in with voluntary sector organisations.
Okay, thank you. Thanks, Katie. I think actually Healthwatch is part of that network, but you're right, it's something that we're looking to grow in terms of the linking across and realise the value, you know, the valuable nature of that network, I think, in terms of supporting these kind of things. Okay, well, I haven't got anyone else indicating, in which case, Mandeep, thank you very much for the report. It's really, I say, it was a service that I knew like next to nothing about, so it was a really interesting report to me. Okay, so we move on. So I have had a request around people that need to get away, and so after the, I think we've got time. So what time does Esther Blake need to be away by? Esther, was it 3:30? No,
I need
4.
Yeah, at 4 o'clock.
Right,
I need to be in another meeting by 4. So
what I'm going to suggest then, because I think we can do is we do the developing the, well, we've got the winter access of the ICS and the developing the integrated care system. We sort of connect. So, Katie, are you doing the winter access? I haven't got the.
I didn't receive a report, Chair, so I'm not sure who's presenting that. If they're doing it,
If
just,
at all, you
just
could
giving
roll
an
out
update.
Yeah, sorry.
I could just give a brief update, or Andy Jacheski can. So basically, apologies for the fact that you haven't actually received an actual report, but just to sort of summarise, actually, the Winter Access Fund has been made available from the beginning of November through to March this year, and that is there to build resilience and improve patient access. The funding is available on a weighted capitation basis and will be deployed based on the actual system's ability to demonstrate value and identify quantifying the scale of increased capacity and expected impacts. This has been specifically in respect of improving access to urgent same-day primary care and by the resilience of the NHS urgent care system during the winter. Now, Bob ICS has received applications from all Reading primary care networks, and the Bob Integrated Care System is currently preparing a paper, a briefing that actually can be utilised for public access on the role of the actual winter access funds. And I'm sure that I'll be able to release this through to Nikki to make sure that's been widely circulated. I believe it's still being drafted at the moment. All PCNs in Reading will be receiving funding in respect to this, and most of the actual requests around funding have been linked to actually ensuring that they've got ways to increase the actual access to urgent and same day. So a lot of the actual requests were around about staffing, but also it's about training up, especially the new roles and new staff have been brought into PCNs, enable for them to actually manage, obviously, the urgent on the same day primary care access. So I think it's, to summarise, what we will do is we will make sure that this paper is actually sent through to the Health and Wellbeing Board, which it can then be circulated. The picture of what the picture will be of Bob ICS as opposed from what's happening in Reading. But it's fair to say across Bob, most of the actual PCNs had exactly the same applications.
Okay, thank you, Katie. Yeah, if we get that circulated to the board, and it sounds like it's something that will be interesting to see how it actually works in practice and how the money was effectively used. But yeah, if we get that circulated, and then we can. So thank you for the update. Okay, so what I'm going to propose then, we take our integrated care system. We've got James Kent has joined us for the meeting, which is great. And then I'm going to suggest bringing the children's safeguarding up one, just to make sure that we've got Esther Blake here for that, and then we'll just continue on down the agenda as it's written, but we're getting through it. So, James, asking people to introduce themselves, James, to the meeting when they speak, because there's lots of people on here. And then I guess hand over to yourself. We've also got Catherine Mountford, you've come up on my screen as well, but I'll
Catherine's my backup, so she'll tell. So I'll talk it through, and Catherine will course correct if I say the wrong thing. But Councillor Hoskin, thank you for inviting me. Thank you for the space on this agenda. For those I've not met, James Kent, I'm the lead of the integrated care system and also the accountable officer for the 3 CCGs within that system. Can I just check? Is it fair to assume that people would have read the slides and therefore it's easier for me to give maybe 5 minutes just overview that people can follow along in their packs, but rather than go through a sort of slide by slide?
That's absolutely the approach we'd like to take. Thank you.
Fantastic. So very briefly, in context for this, we are looking to create, effectively put the integrated care system onto a statutory footing. So that's the legislation that's currently going through Parliament. So all that we'll talk about will be subject to that legislation both passing in the way that it is currently written, and obviously many of you know it still will have the amendments and various other bits and pieces working through. But unlike these slides which say we were looking to put the system onto a statutory footing in April, the new timetable is July, and again that's been effectively driven by the parliamentary timetable to make sure this thing is can get through Parliament. In terms of what putting on a statutory footing means, it would create something called the Integrated Care Board, which would be a statutory organisation that would take essentially the staff that currently work in the commissioning architecture, the 3 CCGs. It would employ them, and the CCGs would sunset, and on the same day that the ICB gets created. But in terms of how we build that, the focus of it, the priorities, how the governance works, the membership of some of those governing bodies, those governance committees, that is for us to shape locally. We're given plenty of guidance, as you can imagine, but we are allowed to shape locally, and so therefore this is the beginning of the conversation as opposed to a fait accompli of here's where we are. So that's a bit of the context. The second thing I just wanted to flag is that it is organisationally it is a change, but strategically it's the same direction. So the goals of the Integrated Care Board and the system remain the 4 that broadly were in the long-term plan, around improving health outcomes, improving inequalities or reducing inequalities, financial sustainability, and supporting social and economic development locally more generally. So those were in the long-term plan. You can argue, so in that sense, what these changes are trying to do is accelerate and enable us to deliver on those missions better than we can today. Page 5 of the deck just outlines some of the key components, and for those that are not steeped in the NHS, my apologies that the number of acronyms here is almost too much to bear. And even if you are close to it, we keep changing what the acronyms stand for, so it is quite a jumble. But let me just try and explain. So the first piece is there is as I said, the commissioning architecture will turn into something called the Integrated Care Board. So that's the sort of 300 people that currently sit in the CCGs will move automatically into that. That will have a board that will obviously set in resource terms, will help design a strategy, but also will help resource allocate around that, and effectively is the executive of the system. Above that will be something called the Integrated Care Partnership, which is a joint committee between the NHS and each of our 5 local authorities. Open brackets, we've not done that before, and that might be quite tricky, close brackets. Then the integrated care board itself will then have underneath as committees will include place-based partnerships. So for Berkshire West, that's evolving what is currently the unified exec, but giving it effectively, we want to try and work out how do we delegate down accountabilities and budget to that place-based partnership, such that, so in a way it's a morph between the current CCG and the unified exec is one way to sort of think about it. I think the final thing I would say is that the first thing that we will be asked to do is to create the strategy for the system. And unlike any other system in the Southeast, we do not have a singular focus. So every other system either has a county boundary focus or, in Frimley's case, a hospital. We don't. We have 3 strong places. And I know someone's about to say, no, we have 5 strong places. So we have more than one. We don't have a singular focus. So this is a system that will be made up of strong places. It's not a single piece. So when I talk about system strategy, that will be an accumulation of 3 place-based strategies plus some of the work that we would do collectively across the system. And we would see the health and well-being boards locally as the equivalent of what the ICP is to the board. We would see the health and well-being board being the group that confirm, if you like, and endorse the strategy that's created for local place. The final thing to say is that people obviously fear things like this coming along and feel everything people talk to me about, it will all get sucked up into ... The care will still happen in the providers where it happens today. Most of the management of the operational and the transformation bits of that care will also happen in place today. So if I think primary care is place, urgent emergency care is mostly place. 9s and 1s are different, but mostly place. A lot of the long-term conditions are place. So the system role is partly orchestrating some alignment best practice here, but also partly operating and trying to work out where we can get synergies across, particularly some of our acute trusts where we're sort of load balancing on electives or at the more tertiary level. The vast majority of interactions that people have within the health service is obviously in primary care and around long-term conditions and UEC, and that will remain managed. Actually, I was going to say remain managed at place. It might be even better managed at place if we can actually get if we can actually get to true integrated care. And the final thing I would say, and then I'll pause, is that for me, the greatest value in all of this is the legislation is going to take competition out and insert collaboration in. And that actually will open the door for us genuinely to be able to do integrated care. In other words, we will have one pot of money, one workforce, and therefore we can create teams that can look end to end across a service rather than the constant handover between one and the other, and the silos which naturally you get when you're in a competitive sort of environment. So that's the holy grail we're after. But I will pause there, Graham, because I think normally these things are better with people asking their questions because everyone's got slightly different contexts and depth of knowledge, so I can take anything from anyone. And if, as I say, Catherine will tell me if I've buggered it up, basically.
I'd like to see that. Okay, does anyone have any? I mean, I do, but does anyone have any questions or anything they want to? All right, I've got Councillor Liz Terry has indicated. Liz.
Thank you, Chair. I'm sorry I've not had a chance to ask you about this. In the governance, the ICB board membership, does the 3 partner members mean councillors?
No.
No. So before you answer, James, I was just reading up. There was an interesting debate in the House, I think, of Lords about this and about the Constitution doesn't actually include MPs or indeed councillors. I'm not particularly strongly arguing for MPs, I have to say, but I am arguing for, well, because it's a big area, but I am arguing about local councillors. I mean, we had some discussion at our ACE committee on Monday about a number of things, and I just genuinely have some concerns about the sort of democratic involvement in these sorts of bodies. Yeah. And we do represent our communities, and we do see, this does seem to just carry on the sort of taking things away, really. And I kind of would be interested in your thoughts about how you might be looking to have democratically elected people involved in this process.
Yeah. So so I shouldn't have just said no straight off. I should have started with yes, but anyway, what we're trying to do in the structure, you've got a place-based partnership, and in each place then the health and wellbeing board sat above. At the system level, you've got the integrated care board and the integrated care partnership sat above. So the councillor and the democratic representation would be in the health and wellbeing boards, and we would expect to try and create some common membership between those, and then I can see it's not going to go very far, but let me finish and then you can shoot me down. And then likewise we would have councillors and elected members in the integrated care partnership. So that was where so in some ways you can argue, particularly because the strategy at place will also help drive the resource allocation at place. I would actually say you could argue the stronger democratic accountability if we can get it right. I think the final thing I would say is obviously, we have some degrees of freedom on some of this, but not many degrees of freedom. As you say, it's statutory definitions that are going through the House, and you are also correct that there are various debates exactly how local authorities fit, and both on the sort of official side as well as the democratic, so the elected members side. That who knows, that may get amended as we as we run through. So this is where we are. It may not be perfect, but that's the. You can come back and shoot me down.
Hence, James, can I just?
Course correct.
So it's not course correct. It's just at the moment we are specific. It's a specific exclusion that you cannot be a councillor or an MP and be a member of the ICB board, and that's currently what's in the draft legislation and the guidance. So we're governed by that currently, but if it changes,
yeah. So Graham, you'll have to forgive me because I am shortly just going to leave, but it is exactly the point I'd like to make to everybody else on this call, is that all the arrangements are being, I think the House laws make a point really. Everybody's going ahead putting these arrangements in place, but the legislation hasn't actually been all the way through yet. So this sort of feels a bit of the horse before, the cart before the horse stuff. And I doubt that it will change, because democratic involvement in health has always been quite a struggle and difficult. At least when we had PCTs and we've had the CCGs, it's been some sense, at least we know the people and it's local, and yes, the health and wellbeing boards, but I think there are some big buts about the constitutions being proposed and the democratic involvement, and therefore the disenfranchisement of most of the residents of Reading, in my case, in my opinion. It's only my opinion, of course, but we'll see how it goes. But I just think people should note that.
Yeah, no, thank you, Liz. And in fact, it's not obviously just us, and I'm sure James and Catherine have held this right across the board. The local government association and particularly exercised by the dangers that local authorities are actually going to be pushed away from the influence of the really strong trust, particularly the hospitals and the acute trusts, will become more and more powerful than the system, which is what I don't think where anyone wants. So I suppose to summarise, Liz raised the point I would have done, that we over the next number of months, understand how the role of the local authorities and the sort of democratic accountability will work, as well as the strength of place. But let me bring in, there's a number of people indicating. I think the first person was Mandy Baines.
Thank you, Chair. Yes, Mandy Baines from Health Watch Reading. Thank you, James. I think my question follows on from Councillor Terry, really, which is, with such a large system and as articulated by you, it's quite complex and diverse, how do we ensure the patient and public voice isn't dissolved within this system? And I see that there's 2 spaces for non-executive directors, but with such a complex place and 5 places, is 2 the right amount? And how can you reassure us that Health Watch, with its statutory duties, and the patient and public voice will still remain at driving the services in the direction they need to go?
So I think so you're right, I'm just on the non-executives, Andy. There is a minimum of 2. I think it's still, in a way, I think Javid Khan, who's the sort of chair, and I think we're setting up for him to meet with all the health watches, is sort of taking views on how we might want to evolve the constitution. So to be perfectly honest, we put in almost the minimum required constitution, but we're very clear that we would change it once we actually have people in place with it. So first of all, we're on 2 because it said minimum of 2, but it's easier to add than to subtract. So that is one place of it. Obviously, Healthwatch and others are on the health and wellbeing boards, which is why we want to try and strengthen the role in terms of the strategic there. And I think Healthwatch would also be on the ICP. So we'd have those pieces of it. I think the third bit is, as we think about how do we craft the strategy over the first year, I think we have a lot of ambition to do quite a large amount of patient engagement, because I think partly because we've got a deficit through the pandemic for a whole host of different reasons. And so even just catching everyone up on the stuff that we're doing part of the long-term plan, I think is important to do, as well as actually how we want to take this forward. And the reality is we have to make real choices, and I don't think you can do that without, in fact, we know from scrutiny and others wouldn't let us do it unless we've gone through proper processes as well. I think the piece that requires some co-creation is what's the right place of getting further patient voice in. So at one level, the mechanisms are there, because we have them in each PCN and all. But do we want to try and do that as is there a patient voice group that works at place, or do we do it by different sectors and topics? I think that's still for us to shape, Mandeep. Actually, I don't think that's not sort of dictated in the legal framework, but I think it's really important that it's the same as the clinical voice. We need to work out how do we put those additional structures in to make sure that the decision making is based on the right number of perspectives and the voices of all, as opposed to not being that. So still to design. That's why it's really important to say this is the beginning of, as opposed to ta-da, here's the answer. This is very much a sort of I think the legislation gives us a scaffold. We have to build and embroider around that scaffold collectively together, so we've got something that is we're comfortable with. As Liz was saying earlier, we may not be completely happy with it all, depending on what the legislation is, but we need to work out how to make the best of what's handed down to us.
And again, if I can add, as Mandeep, as you know, but for the rest of the committee, we've had again a very early start conversation involving health watchers, trust governors, volunteering community sector, in terms of that, what is the best approach to patient and public engagement and voice, and how do we build that together, and we'll continue to work in partnership to develop that.
I've got Shona Douglas, I think, the next person. Shona. You're muted.
It's Tracy next, Graham. She's before me.
All right, thank you.
Tracy Dasovich.
Tracy.
I'm very happy for you to go, Shona. Thank you, Chair. Tracy Dasovich, Director of Public Health. James, you'll probably be able to guess my question. In terms of the structure, at the moment, public health isn't mentioned as a standalone option, and the role of the Director of Public Health isn't specified. My experience of this in my previous role in the ICSs when they were starting out, I sat on the most senior board as the DPH and also chaired the Health Inequalities and Proactive Care Group, part of that. And in my last role, when I was overseeing 7 systems within the Southwest, again, public health had quite high prominence, but we don't seem to be visible in the structure as it's described at the moment, which obviously doesn't mean it's there. I'm aware this is still being created, but where is public health in your thinking, both in terms of health inequalities, health equity, prevention and proactive care?
So you're right, it's not prescribed, but I don't think, and therefore you won't see it at the moment because we went for the de minimis option as opposed to what we thought was the answer. I think it is important that public health is there, and actually, again, setting up time with you and the other DPHs and Javid to try and work through where we think that best sits. I mean, at the moment in this system, there is we do have a a board that AMSAF and I co-chair on inequalities, but I suspect in the new world we would actually have a formal committee or subcommittee of the board that would be inequalities as well. So we need to work out where it fits. So I don't have the answer, Tracy, but this is why I think we need to evolve it, because actually the answer is clearly you need to be somewhere. We need to work out the most value-added place. Is that place system? Is it on inequalities? Or how do we think about that? We need to work our way through. So I don't know why it wasn't in the original prescription, but probably because no one could work it out. But we do need to work it out, and we need very happy. And you should already have, an invite from Javid to start that set of conversations.
Oh, welcome that. Thank you, James. Appreciate that. Thank you.
Okay, thank you. I've got Shona Douglas.
Yeah, thanks. Hi, I'm Shona Douglas. I'm Exec Director for Social Care and Health. Hi, James. Thanks for that. I guess mine's not a question. It's just a kind of a comment and a sort of kind of plea, really, because when we had our CQC system-wide review way back about 3.5 years ago, one of the things that it did was it brought us together in Reading, and actually it influenced West Berkshire and Wokingham equally around that, around our Home First principle and the value that the council, and sometimes I suppose a bit like Tracy, those wider issues other than just social care, have in the whole system-wide economy. And I guess I suppose it's just around the same issues as public health, James, is around making sure that councils are kind of, prominent in that, and that we can be leaders in some of that, I think, actually, because we've got three really good systems in many ways, very different, but very good. I've worked in all of them as well, so I kind of know those nuances. So I think that was the kind of plea, because we have developed such a solid relationship in the West, which does work, and the kind of nuances we had years ago around the tensions of the different language, we kind of all now know we talk different language and have those open and frank debates, which make it a really healthy environment to work in. But I do know I just don't want us to lose those wider elements. And I think the other bit is just the kind of issue which, Councillor Terry raised, that we had the discussions at ACE the other night, is around, that we've got our adults, children's and education committee, and that health is part of that forum in terms of, discussing those local areas and having the scrutiny and raising the profile of some of those works in the public domain. So it's not a question, it's just an ask in terms of the considerations as we're going forward, which just feel really important when you're sitting in a local authority, knowing some of the things you can do, and having sat in the unified exec, kind of seeing some of the benefits we can have where we do things together, is we can get there if we kind of think more broadly. Thanks.
No, that's good. Thank you for those. A couple of thoughts. So one is, obviously want to build on the unified exec, might change its name, but in fact we don't really need to do that, we could still call it that, but anyway, it is. So we're building on, as opposed to trying to sort of wash away and start again. So we're trying to build on. As you know, the inequalities focus will actually widen out, because obviously we've got the wider determinants of health. I think that's part of, for me, that actually is part of the value of that focus. It actually helps weave in a bit more. The third I would say is, I think the vaccination programme has shown just how much we can do when we work together, which I think has also been enormously helpful. And then I think the final thing I would say is, this is a personal view, I do think because the legislation has come out of DH, it is over NHS. So in other words, that group don't want to sort of dictate what should happen on the local authority side. So you've got this paradox that, in a way, you're written into the script. There's less local authority pieces written into the script. On the other hand, we've still got the flex locally to write in as we want to write it in. So I think we should generally take that as a positive, because I'm not sure if it had been scripted in, it would be the right script. Don't quote me, but I do. So I think if we just sort of think of it in that way, which says, okay, let's keep building on, what we've already done and seen successful locally. I think we build on that as opposed to anything else. But thank you for the comments, appreciate it.
Thank you.
Thank you.
I've got Andy Czerski indicating. Andy.
Yes, hello James, hope you can hear me. Hi. Thank you for the presentation, and I think, in fairness to yourself, it's a complex situation in Bob, because actually you've got 3 places to bring together, rather than in other ICSs where they're just bringing one CCG into one new nomenclature. And as you know, Berkshire West has made its petitions to you to give us some independence to do what we do well, because we have done it well for a long time, even within the new structures. So just to let everybody else know that I've been involved in some of the primary care discussions about how GPs, PCNs are represented within the new structures. And we're also just starting discussions with our local colleagues, with the community services, with the Royal Berks, as to what the local place-based partnership might look like, which is an involvement of the unified exec. So we are trying to keep the Berkshire West voice up, and obviously within that, the individual voices of Reading, West Berks and Wokingham. How do you see that working going forward, James? How much slack will you give to the local places versus how prescriptive you'll be from the centre? Thank you.
I don't believe I'm allowed to use the word slack, but I might use the word empowerment. So for me, I think this is the, let's just slay the myth here, right? So the myth is there isn't going to be some big thing somewhere in the centre that's going to sort of suck everything up and have some give out bits of money on a daily basis provided certain criteria are met. The aim here is to delegate down to place the vast majority of the funding for the vast majority of the services. So that's the mission. I think so if you took unified exec, how would that change? We actually might be some strengthening of it, but we would want, for example, as soon as quite quickly to work out how could we give it most of the UEC budget, for example. How could it have greater say and potentially then control over things like the local commission service elements around primary care that would support some of those things? How's it set up integrated care along a pathway like cardiovascular that needs, where the core integration is primary and secondary, but also it includes some of the preventative and other pieces. So for me, that's the mission, is to empower. There is a piece of aligning so that we can partly to make it manageable, but mostly to make it comparable, not to make it the same, but to make it comparable. So, for example, I take some of the discharge to assess pathways and discharge pathways at the moment. I'm doing a piece of work to try and understand why have we got different pressures in each of the 3 places in different elements of that pathway. Because I think if we generally were able to understand that, we'd probably be able to understand a little bit better how to best optimise that those pathways. And I think it would be equally valid for Berkshire West to understand Oxford and Bucks as the other way around. So there is a piece of that requires having some commonality of language and some commonality of definitions, but I'm not looking to, it'd be stupid to try to do cookie cutter each place into the same format, because they're different places, different size, different histories, different starting points, etc. So, should we have common outcomes? Yes, probably. Should we measure them in the same way? Yes. Would it be helpful to have similar committees type structures? Yes. Do they have to be exactly the same? No. Will the provider collaboratives or the place-based working be exactly the same? No, everyone starts from a different place. So I think so, but can we learn from each other? Yes, we can, and there will be some areas where scale is important and some areas where being local is more important, and that's what we've got to work our way through.
Thank you.
Okay, thank you. I haven't got anyone else indicating. Hopefully, I'm sure where those questions were coming from were at all a surprise in terms of our concerns around the strength of place. And even within our place, we've got quite distinct areas, haven't we, within
exactly.
Wokingham, so it's even more complicated. And we haven't mentioned, of course, that the 3 places have health and wellbeing strategies which have been developed and signed up across partnerships. So that's something as well as sort of unified execs and what we've got to work on. I certainly share concerns around the role of public health. We obviously have integration white paper apparently coming from government, which will influence how we all work together as well in ways we just cannot predict because the rules are so contradictory, but that'll come. I suppose what I would say, thank you very much for coming along. Hopefully this is going to be the start of regular connections and communication, so that this board feels very much connected to developments. I don't think I need to emphasise, also, you want to maximise the empowerment of the local. You're looking at the 4 goals, certainly 3 of them, if not the productivity and value for money, which you could argue as well, very much best delivered in communities, in local places. And I think one of the challenges, and I don't think you're going to have an answer to this, James, maybe you might, but one of the challenges we've got is that a lot of the mechanism that you could address things like around inequalities, public health, wider social determinants would ordinarily sit with, well, it does sit within councils, are very strong around that, but councils have been very much strangled in terms of their financial resources to be able to deal with a lot of these issues. Public health budgets have been cut. The NHS isn't in such a bad situation, but has huge demands placed upon it to meet. So I just wonder how we work together to ensure that money is best spent in the best way when we're looking at more preventative work, when we're looking at trying to reduce illness, reduce people's need for health services. If we just carry on the old way of just pumping money into hospitals and to health services, we'll never address that. So I don't know. That's something. I'm not quite sure that this new structure gives us the best way of addressing that, but maybe that's something that we can do together.
It does give a couple of things, Graham, if I may. So the first thing is So I agree with you. There's one of the challenges here we have cost shifting, or what people call shunting, don't they? And sort of because we have cost shifts that happen across the 2 boundaries, and to be honest, we don't really know what those are. I think each side feels they're getting stuff shoved to them from the other side, but that can't be. Someone has to be a net winner, and it always feels it's the other side. So I think the piece that is first of all helpful is by taking out the competition and pushing in collaboration, it makes it easier to create common fact bases. As the local authorities join in, that's what we're trying to do around the discharge pathways, can we actually get to a common understanding of what's actually happened? So discharge is really good. Health has put more money in. I think local authorities say, well, we've put more money in, right? So we've got to work out, well, have we got the right model? And actually, we could be really clear and transparent over what's the total we're putting in, and then start to work our way through how best to manage that. We could do the same thing I think the second thing I was going to say is that, in Berkshire West, you've got, good patient level data and access and things like connected care. We need to work out how to use that at a population health level. So we take something like alcohol and sort of say, okay, well, where's the preventative strategy? How much is that costing downstream? Is it worth that? You can only do if you've got a set of partners who are willing to share the data and actually also have a shared view about clinical risk. Because obviously we could all put more money into most things. So what's the right way of thinking about the clinical risk? So I think if we could get to those, actually I think we could get to a much more mature and understanding of how to best use the money. And then if the legislation changes the Better Care Fund to make it more flexible, we could use that as the vehicle. But that's downstream. We've got to first of all be really clear what's our total spend, and then how do we think it collectively? How do we shape how to spend that? At the moment, we don't do that. Actually, we can't really unpick what's in the Better Care Fund, what the hospital spends on discharge, what Julian spends on discharge, what primary care is doing. We can't unpick it very well. And I think that's let's invest to try and do that. And collaboration allows us to do that, because it takes out well, I don't want to reveal my costs because I'm trying to bid for more. It takes that piece out, which hopefully is enough, but enough with a push. Anyway, that's my sunny uplands Friday afternoon.
Okay, thank you. And I haven't got anyone else to get. Thank you very much for coming along. So it is really important that we maintain that collaboration and conversation and communication continues.
And so if you feel you're short, obviously ping, and we'll happy to come back. Otherwise, we should probably come back every 2 or 3 months anyway, just to sort of keep the uptake flow. But if at any point you feel out of communication, just shout.
Thank you very much.
Fantastic.
Thank you.
Very good. Thanks, everyone. Thank you for the time.
Thank you. I'm going to jump because Esther needs to leave by 4, so we're going to go straight to the children's partnership. There's Esther, which is item number 10. Everyone has to remind me to go back to number 9, or else I'll forget, but it's page 265 to 288. Esther.
Thank you very much, Councillor Hoskin, and thank you for just allowing me to bump up the agenda very quickly. My name is Esther Blake and I'm the Partnership Manager for the Berkshire West Safeguarding Children Partnership. It's my first time presenting this report to their Health and Wellbeing Board, so thank you for having me along. As you know, we moved from local Safeguarding Children's boards into new partnership arrangements, probably coming up nearly 3 years ago now, but this is the second report under this new format that you've received. As with these kind of annual reports, I appreciate what you're seeing is something that's already almost a year out of date, but actually quite a lot of the information within it spills on year from year, the risks that we see year from year. And what I recognise hearing Deborah speaking earlier is actually she will have been updating you on a number of the risks and the work ongoing. And this year's report particularly focused on the impact of COVID and how the Safeguarding Partnership responded to that. And I think from hopefully you'll have seen as you've read the report, actually there was a really strong response from a strategic point of view with senior leaders coming together really regularly when COVID first struck us, to make sure that any concerns around how the different organisations were responding to that crisis were coming together, and the safeguarding elements were really being thought through and changes in practice put into place as a result. This report is a Berkshire West report, so it is general in terms of how the partnership have responded, but hopefully what you've been able to see throughout the report is there's very specific references to the 3 local authority areas and a number of references for work that was undertaken specifically in Reading. It's really important, although it's helpful for a number of our organisations and for our communities actually, that we look at safeguarding over a wider footprint and make sure that we're working effectively together. But each local area has its nuances, and it's really important that colleagues working in Reading feel that as a partnership we still have a focus on the specific community and risks in Reading. So we have subgroups that are still very focused on Reading and the risks there. And I think what you'll see in the report is that there are some of the priority areas, and I know Deborah spoke about it earlier, the serious youth violence area and that adolescent risk priority that's really key in Reading, and that thematic child safeguarding practice review that she mentioned earlier is a key part of that work that we're doing, and the learning from that work in Reading will be then shared across Berkshire West for our colleagues in the other 2 local authority areas. The front sheet that accompanied the report, I tried to pull out some of the more health-orientated pieces of safeguarding work that had been undertaken in the year that we're talking about, particularly around the online youth counselling service, which I think was a particular positive that came out of that year, and the Navigator programme in the hospital that was set up during that year and has been continued to be ongoing. I think as a partnership, it's progressing positively. There are always challenges, and we have much work to be doing as we carry on through this year and into next. There's some strategic work that Deborah and her executive safeguarding committee are working on to make sure that we've got the right scrutiny and challenge in place. That's been missing for us over the past year, and although we have had scrutiny through our serious child safeguarding practice reviews that we've been ongoing, that's an area that we need to develop going forward to make sure that we are really being able to evidence impact of working in these set of partnership arrangements. I know you've all seen the report, so I won't go into any more detail, and I'll just open up for questions.
Great, thank you. Thank you very much for that overview. Questions or points? Anybody wants to raise. There's normally a little bit of a delay while people are thinking about what they have. I mean, I looking at, I was incredibly important reports, and I suppose what was pleasing to see that was the continuation of the kind of partnership work. Just the sense of them coming together in order to protect children and young people, which you sort of worry about over the past year or so. Obviously you expect that to continue. In terms of the last sort of couple of years that we've had, I presume one of the challenges also about how we ensure around the distance between sort of the partnership groups and the board, people represented in the board, and communities and families, that becomes a greater distance and therefore makes the challenges harder, and things like involvement, co-production, and working with voluntary community groups. Has there been challenges around that have had to be addressed, particularly over the last couple of years, or I don't know if you have any thoughts?
I would say that's always actually been a challenge within these kind of safeguarding arrangements, because the focus always seems to be at a high level. We have the strategic conversations and actually making sure that we're drilling down and having an impact for the community, and that there is a point that we're having those conversations. And that is something that we're really clear when we recruit into our independent scrutineer role that we're about to start recruiting for, that's one of their key points, is for them to come in and really push us forward with that area, because that, although the practitioners are always speaking to the families and the children, and that's their role, but how we hear those messages back up to us and how our messages get back down out into the community is really important, and that's an area that we do want to progress and definitely improve on. But you're right, it's hard. We can focus very much easily on the process and the groups and having the discussions, but it's making that impact out in the community is key. But we are keen for voluntary organisations to come and sit on our groups, and that does happen, but in pockets, and it's something that we need to improve.
I can't see anybody else indicating, in which case, thank you very much. I found, well, as ever, it's quite as well. There's a few things that we do that are so important, are there? I guess in terms of as a partnership. So thank you very much for the report and the overview, and some areas to good work going on, some areas to look at and improve. So thank you.
Thank you.
Okay. Thank you very much. Right. So. Thank you. So let's go back. There's a great deal of reports and paperwork, except on the computers, for the adult safeguarding board report. We do have Teresa Bell. Teresa and Shona coming up.
Yeah, I'm here. Thank you very much. Yeah, thank you very much, Councillor Hoskin. Really pleased to get the opportunity to present the Safeguarding Adult Board annual report. So it's continuing the theme really on from the discussion that we were just having around Esther's report. So I'm Teresa Bell, and I'm the independent chair of the West of Berkshire Safeguarding Adults Board. As you know, or just to remind everyone, is a statutory requirement that each local authority must set up a Safeguarding Adults Board. It's been that way since the Care Act came into being in 2014. And we have a strategic role to oversee and lead adult safeguarding across the area. And it's up to each local authority to decide how they want to constitute their Safeguarding Adults Board. And what was decided some time ago now was that there would be a shared Safeguarding Adults Board across West of Berkshire. So much like the Berkshire West Children's Partnership, this board also covers Reading, Wokingham and West Berkshire. So you do have a lengthy paper in terms of the West of Berkshire report, but just for ease of reference, although the report starts on page 79 of your pack, there is a section in there that relates specifically to Reading that starts on page 243. So, you know, you can go straight to the Reading bit, or you can take in the whole partnership view. It's up to you where you want to start. But it's, although lengthy, it contains obviously some really important information about what's been going on during 2021 in terms of safeguarding activity across the patch in West Berkshire. So as well as the local authorities, like the Children's Partnership, we have core partners who include police and health, but we also are a partnership that works hard to ensure that it is as inclusive as possible. So one of the pieces of work that's been going on very consistently over the last couple of years has been to ensure that we have good representation from the voluntary sector and from Health Watch. And as independent chair, I meet with voluntary sector and Health Watch leads in between board meetings to make sure that we are triangulating all the time the evidence that we see from the statutory authorities in terms of what's happening with safeguarding, with the information, really valuable information that they're getting from the grassroots in terms of how people actually experience that. So just picking up on the point that you were making just now in terms of the Children's Partnership. Really difficult to talk about the last year as it was the previous year without mentioning the pandemic. Clearly, what we've had to do as a partnership as well as individual services is to reprioritise our work. What we were doing throughout the peak periods of the pandemic is meeting as a group of core partners to ensure that we were addressing any of the risks that we could see in the system as a result of lockdowns and impact of pandemic. And that was happening in between boards and meant that some of the activity that would normally be taking part in some of the subgroups was delayed. We had to reprioritise to make sure that we were focusing on what we could perceive, what we perceived were the bigger risks at that time. But I must say that partners it was so impressive and quite humbling to work with partners throughout this period, just seeing how people really have met the challenges of trying to keep services on track whilst they were under such significant pressure and strain because of the pandemic. So we are keeping on with our priorities. We have three main priorities that we're focusing on both in the previous year but taking into this year as well, in terms of focusing on self-neglect, and that includes hoarding. And Reading, you will see from the Reading report, have a specific project on that. We're also focusing in on ensuring that work on pressure care is really consistent. We've got some really good practice across the partnership, but we want to make sure it's as consistent as can be. And we are also prioritising our work with commission services, provider services, to make sure that under the heading of organisational safeguarding, to ensure that we have good quality standards in commission services as well. And that's in addition, of course, to all of the usual work that goes on in the partnership in terms of training, learning and development sessions, and the work that we undertake in terms of safeguarding adult reviews as well. In the year that we're looking at, there were no specific safeguarding adult reviews for the Reading area. There were for some of the other councils, but we look at them across the piece. So when we're looking at a safeguarding adults review, we always assume that, okay, it may have happened in that area, but it could well have happened somewhere, you know, in one of the others as well. So the learning is shared across the partnership, and the partnership comes together really well around that focus. So I'm not going to say any more, but obviously really happy to take any questions. Just finally, just to say, I've been in the chair now for nearly 5 years. I've really enjoyed my work with the West Berkshire Partnership, but I am moving on. I chair other boards and I do other bits and pieces of work, so not disappearing entirely, but I thought it was time for a fresh pair of eyes to come in as independent chair. So But I've been really pleased to be part of this partnership and wish it all the best for the future. Thank you.
Thank you, and thank you, Teresa, and thank you also. You've always been very much regularly come along to present this report to the Health and Wellbeing Board and given us a really good overview of the issues. So thank you for that. Got Shona Douglas is indicating.
Yes, thank you very much, Chair. I just wanted to kind of echo on behalf of the partnership publicly thanks to Teresa for the sterling work she's done and for all her input and for building some really firm foundations on this footprint to take us forward. And I know that, you know, we have challenges, and it is a challenge when you're managing trying to kind of oversee 3 areas. But you've set us on the right road, and Teresa's kind of been engaged with us in helping us identify new chair, and the advert is out now currently, and she's supporting us, and that's been hugely helpful. So I just wanted to acknowledge that. Thank you.
Pleasure. Thanks very much, Shona.
Thank you. We can't just praise Teresa. Does no one have any questions or points?
Oh, go on.
Okay, I'm not seeing anything. I mean, I suppose, yeah, I mean, obviously what Shona just said, I suppose the bit that I've probably learned, I suppose, a little bit along over the last few years is the, so as a councillor, you kind of think Reading's all that's important. I've kind of learned through the safeguarding elements and the reports, the benefit of working across, you know, the 3 areas and working together. That's the learning bit. But of course, there's also the bit that, you know, our families and networks don't just exist within our local authority areas, and working together in safeguarding has, you know, it's been really beneficial. So thanks for your work and sort of setting up that, you know, being part of that movement towards that working. Sorry, Shona's indicating again. Was that an old?
Yeah, no, thank you. I don't always want to be first. I always like to give others the opportunity. But I think I suppose I just wanted to flag that really just some of the good work that's happening, particularly around the hoarding and the grant that we have secured, and that we presented that to Adults, Children's and Education Committee the other evening by, you know, the member of staff who's involved in that, and kind of really embedding that because of the issues that hoarding have, which she's highlighted, have been exacerbated by COVID particularly. And I guess, you know, we're just beginning, I suppose, a bit like Deborah Glassbrook talked about, the children's director earlier on, is around the impact of isolation and loneliness and hoarding and safeguarding, where we haven't been having that line of sight as we would have done in the past. And so, you know, we know that there are challenges, and it's very hard for people to kind of operate, but we're working as hard as we can to support families where there are concerns around safeguarding in as fast as we can, given the kind of, you know, onslaught there is when the doors open again and when we've got access to people and people start to come forward again. Thanks, Chair.
Yeah, thank you, Shona. I think that's absolutely right. I will throw something more of a challenge for the future, really, I suppose. The one thing that, actually, no, I've got somebody else indicating, and you might want to just, sorry, it's because of the way this system works. I can't actually, you know, maybe they put down their hand. Right, so thank you very much, Teresa. I suppose it's sort of a challenge for the future that occurs to me, particularly with the approach around removing some, you know, as we move out of the restrictions around COVID, one of the things that worries me is that those people who are, you know, maybe older, might be vulnerable, may have particular concerns about catching the virus, even if they've been vaccinated, could be a whole new challenge of people that are increasingly isolated and perhaps less connected to wider society in a way that we might hope. So I suppose that's, in terms of safeguarding, that seems to be quite a challenge and something that's a concern. So I'm not really asking for any answers, but just throwing out there in terms of as we move forward, we may have less restrictions around some of us, but that may create more isolation for others, I think.
I think absolutely agree with you on that, and I think it is something, and that's the importance, isn't it, of us keeping in touch with voluntary sector colleagues as well, because quite often they might be in touch with those people more easily than the statutory services are. And also, I think just to really reinforce our contacts with carers as well, because carers will be very concerned too about the impact of lifting restrictions on the people that they are caring for. So I think that work at a grassroots level is going to be really important.
Completely agree. Okay, I think can't see anybody else indicating, in which case, Teresa, thank you very, very much for coming along. I guess for the last time to hear, but I hope we will see you about and various different things that you do. So thank you very much.
Thank you. Thanks very much.
Okay, so the next item is NHS Health Checks Programme, page 289. Is that Chris Stannard? Over to you.
Hello. Yes, thank you very much, Councillor. Yes, I'm hoping people have managed to have a look through the report. For those of you who don't know, the NHS Health Check Programme is a statutory obligation upon the local authority to offer a NHS Health Check to all individuals aged between 40 and 74 who are not on a disease risk register for cardiovascular disease, to assess their 10-year risk of cardiovascular disease. So it's a universal preventative programme. So I'd just like to highlight a few sort of key points from the report. Again, for those who aren't familiar with the term, a health equity audit is a process that examines how access to and uptake of services and outcomes are distributed in relation to different levels of need. In more conducive times, a health equity audit would be a long and more comprehensive process involving multiple stakeholders. But unfortunately, due to circumstances, this became a desktop exercise very much. But we looked back at primary care data related to the NHS Health Check Programme over the 5 years leading up to 2019-20. And we've also had a few pieces of more additional evidence from national studies about the health check programme. So I've summarised the process that was undertaken and the findings in section 4.1. And I don't propose to go through all of those, but I'm happy to answer any questions. And the recommendations and the findings we've been using that to inform the design of a pilot of a programme of more targeted checks this year to prioritise those at greatest risk of cardiovascular disease and COVID-19, because many of the risk factors are shared between those two. Unfortunately, due to COVID and sort of the winter pressures in primary care, there's been significant impact on practices' capacity to take part in the pilot. We have one PCN, Tilehurst PCN, and hopefully a second single practice, Melrose and Eldon, who will be undertaking a few targeted checks. Unfortunately, the numbers will be very small. This is mainly due to limited clinic space that is being taken up for vaccination and staff capacity due to COVID. And hopefully those numbers will grow as those factors improve. But at the same time, we've been developing the new service specification for next year to start from April. And we are planning meetings with all of the primary care networks, their clinical representatives, to share the draft and to discuss their intentions to restart checks fully hopefully from April. And there's also been a growing body of national evidence that demonstrates the value of the NHS Health Check programme in enabling that early identification of risk factors and then the opportunities that presents for lifestyle modifications and getting something done sooner rather than later. So, for example, as I said in the report, the data, for example, shows that around 80% of people who have an NHS health check will have their cardiovascular risk score measured and recorded, which compares to 30% of people in primary care systems who don't attend for a check. So there's a really good opportunities for prevention and for conversations about modifying those risk factors. And other factors such as physical activity, smoking, BMI, alcohol, those conversations are held as part of the NHS health check. So it opens up lots of opportunities for getting in early. And there's also been some key drivers within the business of primary care networks in their new service specification, which is particularly around reducing health inequalities and cardiovascular disease risk. So we're looking forward to talking about that in more detail with primary care networks to start the service for next year again. And finally, we're also exploring the opportunities for community provision of NHS health checks. We sent out a request for quotation just before Christmas, and we've had a couple of responses back. So this will give us an opportunity to test the market and to see how community provision of checks could operate alongside GPs doing the same next year. So that's kind of where we're at the moment.
Great, thank you. Shona's come up on the screen. I'm not sure if she wants to speak. She's not, maybe not. So thank you very much for that, Chris. And obviously there's been some real challenges around the health check. You know, there's no point denying that. Even before COVID, I think there was challenges around capacity within primary care. So personally, I very much welcome the looking to prioritise the resource and the health check, where you may get, you know, obviously prioritise with those that are most at risk of poor health and where you might get the maximum impact, particularly on health inequality. So I welcome that. I also really welcome the idea of exploring more community involvement in health checks. I think there's people that may not be particularly attracted to visiting their GP, you know, white coat syndrome. And I think if we can develop both more community-based health checks, but also more community and peer-based sort of support, so people within communities and they trust, you may get more sort of buy-in and action, I think, to people's change. I suppose the challenge is also following on from that about the services and support in place to help people to address what you find. And I think some of that, the answers to that again lie within the community and voluntary groups and people's peers and support. So I suppose that's sort of welcoming the direction, even though it's born out of some challenge. But
yes, the evidence is all pointing to that proportionate universalism as being the way of doing things. Yeah. Did you want to say something, Becky? You've appeared. No. Sorry.
It's always nice to see you, Becky. But I got Mandy.
Comment is, you know, we do appreciate the pressures that colleagues are under in primary care, and we do look forward to having those discussions and finding ways that we can support practices as best we can. You know, we do see this as an important preventive programme which we invest in. But I think it's absolutely right. We do look at other provision as well and how we can strengthen the programme locally. So that's all. Thank you.
I've got Mandeep and then Alice. Mandeep.
Thank you, Chair. Thank you, Christine. I read it with quite a lot of interest because in the past we've had some feedback specifically from ethnic minority communities about the health checks, and it's about how the health checks are communicated to them. So they're most likely to get a phone call from GP saying, come and get this check. They don't know why they're having it, why they've been chosen, and it means there's less buy-in into the future actions that are going to come out of that. So I think in terms of how you develop it and go forward, the communication is really important. And also, I think it's got to really start from that point of why this is good for you. You might know why it's good for them, but have you told them?
Yes.
This is about your ongoing long-term self-care and how you can prevent, you know, long-term conditions. So I think there's a huge communication thing. And when you talk about health inequalities, you know, one of the greatest barriers that health inequalities puts up is access. So you know, going out into communities, that's a great idea, but it's how you talk to them and what you're communicating. And that whole communication message needs a bit of a change rather than a phone call from your good GP. And a lot of people, you know, will do just what their GP tells them because it's important to them.
Yes, yes. No, you're absolutely right, Mandeep. Thank you for that. And I think part of what we need to do, as you say, is improve that communication, but also having more resources available in appropriate languages to share with people. And we don't necessarily have all of that we might need in Reading. So we're going to have to do a bit more creating of our own resources to support the programme. And I think we're definitely up for doing that. But like you say, having the community provision, I think, will help. And there's also some good evidence that actually having community champions for health checks are very important to raise awareness in community groups, and it may be something that practices might want to do for themselves, to have a look at patients that might be willing to get involved with that sort of thing, and we would definitely support that as well.
I completely agree with Mandy. I think I was chair of the Wellbeing board when I got the letter and went to the health check, but the same, it felt very transactional. You have to do it. You weren't really, I think there's a lot of improvement on the whole system, and obviously that's much more important for people who don't happen to be really connected to League Council for Health and white and middle class. So yeah, completely agree with you.
I agree. Thank you.
Okay, Alex, you're indicating.
Thank you, Christine, for the report. Thanks, Chair. I just wanted to, I'm in a ward which many of the residents here in the constituency, they call themselves Down Under, which is weekly ward, and most services don't reach them. They are forgotten. They think that they are forgotten in so many ways. So part of the weekly, which is the Down Under, is the weekly wood side of it. There's the weekly south, which is where the NHS is at the Northumberland and South Reading. That's fine because they are reachable within that sector. But the Down Under part of it is that there's no place where they have a link in the sense of community. And I'm not quite sure how these communities around in Weeklywood can be reached, because most of them, as you know, the dynamics of Weekly, there's a lot of mental health, there's a lot of physical health problems. There's also a lot of other challenges, including that affect health. And it's quite important that we look at the fact that through the small Weeklywood Community Centre that we have, services are not coming down there to reach them as such. So when they present to the NHS in some ways, it will be already too late for them by the time they come. But whereas when there is the community link of that sort, where they know somebody might be coming into the community in the Weeklywood, they can pop around and say, I've got this, and then you try and do something in hand prior to them being admitted in hospital. So is there a way you could try and do that and try and find out how we can do that best?
Yes, I mean, certainly when we're looking at the offers that we've had for people that could services that could offer community provision, that's exactly the sort of thing we want them to show us that they can do and have plans to do that. That's it. That's what it's all about, I think, getting out into those exactly those communities that you describe, Alice. Yes, okay. Yes, that's exactly right. So we'll be looking at that when we're evaluating the responses. That's the sort of area we're looking at.
Yeah. And just to add on to what Mandy said again about the BME communities, I sit in so many different groups, and there are smaller groups that are doing things in them. Some of the challenges that I've listened to are the fact of presenting themselves through knowing the right communication that is done to them. And the one thing that they've brought in is that so much of the things that are happening is that they are hard to reach communities, which is a term that has been used, but they have turned it themselves to say, actually, we're not hard to reach. It's because some of the things that come to us, nobody explains to us. Not that they don't understand the English language that is written, but the fact that some of these things don't suit their cultural orientation, and some of it is very important. Say, for example, mental health and some of the things that are happening which are not cultural oriented to things. It's about understanding how we frame that and make sure that people get to know and understand with those people that are sort of community leaders explaining in their own groups. Yeah.
Would you mind very much, Alice, if I got in contact with you and we can sort of take this further and perhaps talk more about community champions?
Okay.
Would that be okay? I'd be really
that's
interested
fine.
to take this forward with you.
Okay.
Thank you. That'd be great.
Thank you. Take care. Bye.
Great. Thank you for that. Thanks for that, Alice. You're absolutely right. I completely agree with what you're saying there. Okay. All right. Well, thanks, Chris. I think you got a little bit to go away with.
I have.
In that, but I think a general agreement with the direction of travel is what you're also getting, I think, from the.
Good. Thank you.
So we have the Armed Forces Covenant. We do have Jill Marston.
Hello, yes, thank you. Yes, so I'm Jill Marston. I'm Senior Policy Officer at the Council. So just briefly on this report, it presents the usual annual update on the Reading Armed Forces Covenant Partnership Action Plan, which has been circulated as an appendix, with a particular focus on the health-related actions. And in particular, I just wanted to add regarding the action about GP recording of veteran status. Since this report went out, I've actually now got the up-to-date figures on that. So currently there are 386 veterans now registered, compared with 329 a year ago, last December. So yes, that's now increased. So also, in addition to the action plan in this report, I've flagged up the recently passed legislation as part of the Armed Forces Act, which places a duty on public service providers to pay due regard to the armed forces community when making policy and decisions in relation to healthcare, housing and education. So that was recently passed in December. So in response to this, the council is now adding the armed forces community to the list of those that are considered as part of our equality impact assessment, and we'll also be doing some training of frontline staff so that they're more aware of what potential issues could be for veterans. And then finally in the report, it just mentions there's a new PAN-BARC civil military partnership, which has just been set up. It had its first meeting in November. So the aim of that really is to develop a shared action plan across Berkshire, and to sort of coordinate projects and events, get some economies of scale. So that's had its first meeting. There's due to be an actual, well, it's going to be a virtual launch now in the spring, with possibly an actual in-person launch in the summer. So that's in the planning stages. So that's everything covered in the report. I'm happy to take any questions.
Thank you, Jill. Yeah, any questions you want to raise? Now's the time. Yeah, no, thanks for bringing this. Is what I mean, I suppose impressed upon me is how these challenges are not things we're addressing overnight. You know, they're really sort of long-term challenges. So it's really good to see the actions developing to address some of the challenges we talked about, particularly around the you know, the GP registration stuff was good. My question is on the it's action 4, which is around raising awareness and signposting, so veteran mental health services. Some good stuff there I can see. Do we know how effective that has been in terms of, is it the kind of sort of take up we'd like to see, or is it, you know, I just, and Catherine McDermott is indicating, so maybe, I don't know if you've got an answer, or you had it on a different thing. So it may be that there's no, we don't know the answer to that, but that would be something I'd be quite interested in. The actions look good. What kind of effect has that had in terms of increasing access? Maybe talk, well, outside of this meeting, Jill, if we can find that out, we'll try.
Yes, I can find that out.
I
don't know the answer offhand, but we have had in the past representatives come in from the service. So hopefully at the next meeting, which is due in February, I can ask that question and get some answers to that.
Yeah, there must be some statistics somewhere. I'll make some inquiries. Great. So, Catherine, you indicating?
Yeah, thank you very much. So it's nice to see you, Jill. I know I've reached out to Jill over email, and we're meeting next week. I was really interested in reading the paper. So as I mentioned earlier, I'm the Director of Strategic Planning for Berkshire Healthcare Trust. I'm also the exec sponsor for our Courage Network and all the vets community within BHFT. And I was really interested in the reference to the PAN-BARCS military civil partnership, and it was one of the questions I was going to ask next week, so I'm just being a little bit cheeky and asking it now. But I wasn't clear from reading the paper, and apologies if I've missed it, whether that was a local authority partnership or whether it could be broadened out to include Berkshire Healthcare Trust, for example. And I know you've referenced doing an action plan, and I did read through the action plan that you've included in the paper. But I just think there's really exciting opportunity for us to be able to do far more in terms of employment, training, housing. I just think it'd be a really fantastic opportunity to try and join up and then really maximise what we could do for our vets community. I mean, I know you are specifically focused on Reading, but I assume the PAN-BARCS means you've got the Wokingham and West Berks partners on board as well. So it's just an ask to consider that. That would be really helpful. Thank you. Really interesting paper. Thank you.
That's right. In terms of the PAN-BARCS partnership, there was a discussion about who are the appropriate sort of health reps to come along to that. So we can catch up on that when we meet, and I can sort of feedback your thoughts to the planning group so that we get the right people on that partnership. That'd be good. And also in terms of the local partnership that meets 6 monthly, we haven't had a health rep on that at all, I don't think, to date. So that would be great to get some involvement there. And you know, if you wanted to come along to that, that would be fantastic.
Great, thank you. Thank you. I got Andy Czerski indicating. Andy.
Have I demuted?
Yeah, we can hear you. We can't now, though. You've muted yourself. After we could hear you. No, right, back here.
My computer's being rather slow. There's a delay, so apologies for that. Jill, thank you for the report. It's good that we've got higher numbers of veterans on GP lists, but the 386, is that good, or do you think there's more out there? I mean, it's good it's gone up from last year, and in a competitive spirit, because that's usually what gets GPs going. How are we in Reading numbers compared to, say, Wokingham and West Berks? I mean, are we capturing these veterans? Because it's always a challenge to get them, whether when they're registering or we do it every year. We ask the question when we do flu clinics to try and find out, are you a veteran? Some people tell us, some people don't. I know in consultations it often just slips out somewhere. So are we doing well or not, or is there some other repository of data that tells us how many we should have?
I think it's very difficult to know if we're doing well or not. But what we will have is the census, the new census data on number of armed forces personnel in the area, which is due to come out. I think that particular data is next autumn. So once we have that, we'll have an idea about how well we're doing. So that should help.
Great, thank you. I think that's it. Positive discussion there, Jill. So thank you very much for coming on.
Thank you.
Things to take away. Thanks very much. Right. Okay. So the next item is the ICP unified exec. Although I guess we're gonna have to, not the ICP we were just talking about earlier as part of Bob. Completely different one. But anyway, Andy, are you gonna?
Yes, thank you, Chair. So I'll introduce myself again for anybody who wasn't there earlier. Andy Czerski, GP, Clinical Director in Caversham, but I also sit on the Unified Exec as a PCN CD. Sorry, I'm using acronyms. As a Clinical Director of a Primary Care Network. Thank you. So in the spirit of what we were talking about earlier on with James Kent's comment about communication, about the committees within the Berkshire West area, because this is a Berkshire West committee. It's called the Unified Exec, and it's a combination of the chief executives of the 3 trusts of Berkshire Healthcare Foundation Trust. Julian Ems is the chair. We've got Steve McManus, the chair of the Royal Berks. We've got the chief execs of the local authorities or their nominees, and a representation from primary care, which is how I end up sitting on the board. I'm just going to give an outline of some of the discussions that happened back in December, and these are sort of quite pertinent strategic discussions, and they're ongoing on a regular basis and are regularly revisited. So one of the things was talking about updates from the System Leaders Group, and actually James gave us that earlier on, in that he has been appointed as the chief exec of the designate of the new ICS of the 3 CCGs, as they will be when they are combined, and as he's currently the accountable officer of the 3 CCGs. And he also mentioned that Javed Khan has been appointed as the chair designate as well. One of the big business cases we've been dealing with is the rapid community discharge. Again, it's a complex thing because it involves health and social care. It's a program that came into being during the COVID pandemic. I think we found a lot of benefit from it in terms of helping to discharge patients. The national funding that came down with it is going, and so one of the challenges for the system is how to maintain the process and finding the funding to do it. I think there's definitely, everybody has found that it has been a benefit having that way of working, but one of the big challenges is having enough of a care workforce available for when patients are discharged home, and that is certainly where, again, going on from what James said earlier on in the meeting, if we can work as a system to make sure that we are working in an integrated way to maintain the staffing within our system, and making sure that we have a resilience of the services we've got in a more integrated way rather than offsetting between organisations. And that's why actually the Rapid Community Discharge Programme is a very good example of integrated working. On the urgent, the UEC workshop and winter plan, that was about urgent and emergency care. Again, this is a big program. We had a strategy for urgent and emergency care that was developed pre-COVID. It started, it obviously got changed a little bit during COVID with the experiences of COVID. But as we've coming out of COVID, we found that the complexity of the strategy had got too much. So it had a refresh in a workshop, and rather than having 11 objectives, they've been honed down to 4 main objectives. They're not mentioned in the paper, but I'll just tell you what they are. First one was on prevention, staying well and keeping healthy. 2 was admission avoidance, dealing with your urgent care to keep you at home. And that was mentioned again earlier in our meeting about the urgent community response programme. Urgent on the day demand, and that was resilience around primary care and out of hours, and also utilising hospital triage. So again, we had mention about the Winter Access Fund giving extra appointments in primary care to offset the increased demand through the winter. So that would fall under that. And then patient flow through the acute and community hospitals, the Home First model, which has been mentioned today, and the rapid community discharge, which has also been mentioned in the paper and previously, and also the discharge to assess model to get patients home and look at their ongoing needs from home. So the next thing was discussed with the ICP priorities, and it's no surprise that some of those things are in the priorities list as well. So same-day urgent demand, rapid community discharge are in there. Primary care workforce is a big thing, because we're getting staff. It's quite hard to actually employ staff to come and work in primary care. They're just not there. There is something called the Additional Roles Reimbursement Scheme, which is under the we've got extra funding being involved in primary care networks, and such as clinical pharmacists and physician associates and other staff that are coming to work in primary care to support GPs in the role and the work they do. But actually, you know, there's no lack of funding to get extra staff. It's actually finding the staff to come and help work in primary care. Multidisciplinary teams was also mentioned, I think, as part of the work that BHFT is trying to develop, and we've actually started doing multidisciplinary team meetings. They're being rolled out increasingly across the PCNs. We've had the first one in my PCN just this week. And then the last few are cardiovascular disease. Again, that's about prevention. We're talking about the health checks earlier on. There's a big thing about getting blood pressures in primary care, which has been difficult with COVID, getting patients to do their blood pressures at home. How do you risk assess them? And as we know from COVID, there's been a lot of issues with mental health problems, and particularly need to look at children and young people's mental health and emotional well-being. So the 6 priorities that the ICP, the Unified Exec, is working on, and the idea that they're there as priorities is that those leaders that I mentioned are on that committee, can try and unblock any issues that seem to stop programs or initiatives from working in those 6 fields, to try and make sure they stay high on the priority list, and that the teams that are trying to get things done are supported by the highest leaders in our system to make them happen. So that's just the flavour of what the Unified Exec does, and hopefully that gives everybody some reassurance that here in Berkshire West, with representation of Reading obviously there as well, which is important, that the health and social care and our local authority colleagues are working together on these sort of priorities. Thank you.
Great, thanks, Andy. And I suppose the thing with those priorities is that it does say, if I read this right, that sort of health inequalities is a sort of an overarching priority over the priorities. If that's the case, then also that's fine. Can I ask a very quick question? In terms of the on page 2, the piece of work happening in Wokingham Council to map the architecture and work the ICP and the priorities to which that's happening out of the health and wellbeing boards under the overall Berkshire Health and West. I don't really understand that. Is that something that's they're doing and we might replicate across the other areas, or is that something I need to find out about?
Woking always seems to be a little bit ahead of us, so it might be worth asking them what they're doing.
Yeah, they also, I've had to be careful what I'm saying because this will be a public document, but they also sometimes like to think about doing things their own way. So I suppose, yeah, I'll contact them because they, you know.
Yeah, I mean, this is again what we've talked about previously, isn't it? That the 3 areas, that although we try and work in partnership across Berkshire West together on a lot of priorities, there are local nuances. Different local authorities may have higher priorities for certain things. We've got slightly different demographics, and you know, how we spend our finances within the council may well be decided in different ways. And so although the overarching principles that we're working to, as we've discussed with the health and wellbeing strategy being a joint one, are overarching across the whole of Berkshire West, the nuances of how people find solutions to those problems will be nuanced within their own local authority areas, and that's exactly right, that people have some autonomy about how they do it. Thank you.
Yeah, no, absolutely. They're allowed to do, do what they like. I was interested. Okay, Becky's indicating.
Thank you. Yeah, Becky Pollard, Interim Public Health Consultant. That was my point exactly, Andy, was the read across to the Health and Wellbeing Board strategy. So we've got the joint strategy across the 3 local authorities, and then we're developing our implementations plans for Reading, which will be nuanced for our population. So I just think it's really important that we see the link between our implementation plans and priorities alongside the ICP priorities. And it's encouraging, obviously they've identified health inequalities, CVD, mental health, and the implementation plans will come to our next board meeting in March. And it would be really good perhaps if we do some sort of presentation or communication with the ICP about what's in our implementation plans, so that we are able to coordinate plans, resources to address, to deliver our Reading health and wellbeing implementation plans.
Yes, thank you, Becky. And we did have a presentation about the joint health wellbeing strategy at a unified exec. I think it probably a couple of meetings ago, and obviously I think there's a commitment from everybody that we do use the health wellbeing strategy as the principal driver of any commissioning plans and any programs that are being done, to make sure that it does fit within that overarching strategy, with the nuances that I've already described locally as needed, and which you just alluded to. Thank you.
Thank you.
Okay, thank you, Andy, for giving us that. Obviously, I think, you know, what we heard earlier about the Bob ICS and the developments, the strength of the joint working at the unified exec level is going to become increasingly important. So thank you for feeding that back in terms of what's happening. I haven't got anyone else indicating. Time is moving on. It's nearly the weekend. For some of us, I don't know. I won't make assumptions about what people's work they're up to over the weekend. I shouldn't do that. Right. So the next is the Better Care Fund plan, narrative, and we can say the outcome as well. Can we, Beverly? Bev.
We can indeed. Thank you very much, Councillor Hoskin. So Bev Nicholson, I'm the Integrated Programme Manager working across Reading and Berkshire West CTG. So the Better Care Fund plan was submitted within the timelines that we were given. It did come out very late in the year. It was due out in February, and I think it wasn't issued until end of September, early October. So we had to turn it around rather quickly. However, we worked collaboratively with all our partners, and we've got some really good engagement at the Reading Integration Board as well to work on this. So we submitted it on time. It had all of the relevant sign-off, and we've just received the approval from NHS England on the 11th of January. And for those of you that may have read the report, you may notice that there's an error on one of the dates. So I put that we got the South East Regional sign off on the 7th of December, and actually it was the 9th of December. So, but it's all good. It's all been signed off, and that's really, really positive. We did have some updates to the metrics. So we've now got 5 Better Care Fund metrics we've been measured against. So we have started measuring those from October, and that's what you will see in the next report, actually, when I'm showing the progress against those Better Care Fund metrics. But just for anybody that isn't really aware of what the Better Care Fund is, I'll just give you a very quick overview. So the Better Care Fund acts as a vehicle to facilitate some system integration between health and social care providers, and gives us some targeted funding to promote that joint working and achieve those shared outcomes. So it requires the clinical commissioning group, as it is at the moment, which obviously will become the ICS as we go forward, and the local authorities to pool budgets together in what we call a Section 75 Framework Partnership Agreement. And then that is an agreement of integrated spending plan, how we'll use that Better Care Fund allocation to promote and deliver on those integration ambitions. I'm not going to read through the report. I'm assuming people have managed to read it, but I'm happy to take any questions on that, Councillor Hoskin, especially in the interest of time. And, you know, I'm aware that, you know, we'd quite like to finish on time today, so.
Okay, thank you for that. You know, I mean, obviously we do have a different discussion if it hadn't been approved, wouldn't we? I'm not quite sure.
Yeah.
I would have been interested. So any more questions or any points people want off this? Hopefully, what hopefully is the case is people have felt connected to its development and involved across the piece. It's a matter of just implementing now. Which do we move on to the next item perhaps to take a little bit more on that, as I've not got anyone indicating? So, which is the integrated programme update, page 377. So we're noting the contents of that, and we're noting the progress, and we're noting the approvals. It's all under recommending actions. Okay, right.
Thank you very much, Councillor Hoskin. And just to follow up on that, the section 75 document that's referred to is currently is just gone through review through our legal team and is now with the CCG for them to assess it and come back with feedback. And we're hoping to be able to still sign that off by the end of January, which is a tight deadline, but we are hopeful we'll achieve it. So, okay, thank you. Moving on to the integration update report. We have 5 new metrics, as I referred to earlier. The integration board, the Reading Integration Board, is actually responsible for engaging that system working with local authorities, commissioning and voluntary sector partners. We have some really good engagement and good attendance at the meetings, and we had some fantastic presentations from the Long-Term Conditions Board and from the Health Equity Audit, you know, and Ageing Well, actually. So in terms of that intermediate care response and the 2-hour rapid response, to look at how we can all work together as a system to really support those initiatives. Just to give you a quick update on the Better Care Fund metrics. So as I said, there were 5. We've actually achieved 2 of the 5 based on data as at the end of October, which is our reporting period. There's always going to be a lag of around 8 weeks because a lot of the data that we're reporting on now is national data sets that are submitted from various providers. So I'll just give you a quick overview of that. So the performance for quarter 3, so as at October, quarter 3 is October to December, okay, is, yes, 2 of the 5 that we met. One was avoidable admissions. Avoidable admissions looks at the number of admissions that we can avoid for people that have chronic ambulatory care sensitive conditions. So things like diabetes, epilepsy, COPD, high blood pressure, where we can, if we've got effective community care programs and good case management, we can help to prevent people being admitted. And you heard Dr. Czerski refer early on to the multidisciplinary teams. And we've got those running in clusters now across Reading. We've got 3 clusters and they are looking at particular conditions. And I know that at least one of those is diabetes and I believe high blood pressure. So, you know, and that system working will really help us avoid those future potential hospital admissions. The next one is about length of stay in hospital. So there are 2 length of stay targets. One is for those people staying 14 days or longer, and the other one is 21 days or longer. We didn't achieve those targets, but we were less than 1% away from achieving them, which I think in the current conditions actually is really good. And then we have the proportion of people who are discharged back to their normal place of residence. We achieved that target, and we have continued to achieve below the national performance against that target. So, you know, we're doing well in Reading, and I know that the hospital discharge teams work really effectively together. And then we've got admission to residential nursing homes. So we have an annual target for that. And these are permanent admissions to residential or nursing homes. So the target locally for that is no more than 439 for Reading. And at the moment we're sitting at 280. So we're still below the target, but the trajectory at the moment is giving us an amber rating against it. So, there's no need to be panicking yet, but we are very conscious that, we do have these targets to try and achieve, and they are stretch targets. And then the next one is about reablement. So this is one that we retained from the previous Better Care Fund metrics. This is reablement where people who have gone into that service have remained at home 91 days after discharge from hospital. We didn't achieve the target, but as I've mentioned in previous reports, some of that is the impact of people who have passed away during that period. We still have to include them in the numbers, but sadly, if people pass away, then that counts as against that target. In terms of local community measures, we've done quite well in that. We continue we've got some additional beds for hospital discharge. So we already had 4 flats at Charles Claw Court for discharge to assess. Unfortunately, they have had some very long lengths of stay due to some really complex cases, but we brought on board some additional capacity to really support the hospital discharge. And I know that there is a plan to reduce the number of people still waiting for discharge by at least 50% by the end of January. So we're really supporting our health colleagues to achieve that target by bringing on this additional capacity and dedicated team to move people through that system really quickly. Community reablement team length of stay with so they normally have a 6-week cycle. At the moment, they're moving people through the system really effectively within 3.25 weeks on average. So very positive there. Still always a challenge to recruit staff, care staff, and that's been referred to by other members of the board earlier in the discussion. One really positive thing is satisfaction rates for the community reablement team service, up at 100%, which is fantastic, and that was based on a 50% response rate, which is significant. So we're really, really pleased about that. We've got a continued focus on the health inequalities, and particularly in areas of deprivation. So I know that's been mentioned by a number of people earlier on, and the Integration Board, Reading Integration Board, have a responsibility to deliver against the priority 1 and priority 2 action plans. So reducing risk and reducing the likelihood of people becoming unwell. So yep, I think that's pretty much it for my report, but I'm happy to answer any questions that anybody might have, Councillor Hoskin.
Great, thanks, Bev, and yeah, some really interesting stuff, isn't there, in terms of those projects in that report. To see, and obviously it's really been a challenging year against some of those targets. Obviously a lot of real hard work going on. So I think it was a pretty good overview of the report. I don't know if anyone's got any. I'm not seeing any indicate. If you've got any questions, this is your opportunity. No, in which case, thanks very much. And yeah, some of those have still got a little way to go, haven't they? And we'll see. Meeting them, and I should have also said a thanks to the team in terms of pulling together the BCF. I mean, when it started off, we were complaining about the tight deadlines, but it was months and months and months. They might not have met what we expected, and now it seems to be getting shorter and shorter each year, doesn't it? Which isn't ideal, but really good work to pull all that together and to get these things in place.
Thank you.
Thank you. In which case, we're now nearly there to the last item, well, the last sort of proper item, the dashboard. Anybody?
Yes.
Briefly, one of my favourite ones, but normally for reading and digesting. But Becky, please.
Yeah, and last but not least, thank you, and I hope people have had a chance to look at the report. It is quite detailed. It's a standing item we have at every board meeting, and it's for note and comments. and the purpose is really to give an update at the latest data of performance against our existing 6 priorities in our existing health and wellbeing strategy. As you'll know, that's been updated. It was approved at the last meeting, but we're still reporting on the indicators against the existing performance matrix. So you'll see there's a total of 26 indicators against our priorities, and overall 12 of those are green, which is great news. It means we're hitting our targets. Red, we're below targets and not meeting our aspirations, and 4 are placeholders, which we don't have regular information on. So I just wanted to highlight those that we're off target, the reds. And I think they're really important areas, as we've discussed through the meeting: childhood obesity, smoking, particularly in routine and manual groups, health checks, those invited to health checks, but also those receiving a health check, adults receiving as much social contact as they would wish, and then looking at emotional and social mental well-being for pupils in primary and all age school children. Mortality rates for suicide and undetermined injuries, we're off target, and numbers of people successfully going through alcohol treatments, and finally diagnosis rates for people with dementia. And I have to say, these are sort of long-standing. If you look across the year, they're stubborn. We really, continue to need to prioritise, which I'm glad to say, if you look in the new implementation plans, which I mentioned earlier, will be coming to the March board, you'll see those areas, those key areas of lifestyle and mental well-being reflected in new actions, new programmes to address those. I think there's no doubt that COVID has impacted the delivery against those indicators, but we can't use that as an excuse. We have to continue to address those areas. And just from a Reading Borough Council perspective, we've certainly highlighted 2 areas: the smoking quit rates for routine manual groups and health checks as key corporate priorities for next year. And obviously, as Chris presented earlier in the meeting, we see that as being a key plank to work with partners to address that. Yeah, more work to do. We're also, the report sets out that we will be coming with a new dashboard against the 5 implementation plans for the new strategy, and I'd be recommending to the board that we continue to use some of our existing indicators in that new dashboard to make sure that where we're an outlier in Reading, we're keeping that focus and keeping that monitoring going. So I'll stop there, and I'm happy to answer any questions.
Yeah, thanks, Becky. And yeah, completely agree in terms of maintaining some of those, those indicators, particularly the areas that we've known some time. We need to concentrate on some that are rising through, not unexpectedly, partly as a result of COVID and the situation we're in. So no surprises for me there, but obviously some areas of real focus that we need to maintain. Andy Cichersky's indicating. Andy.
Yes, thank you, Chair. Quick question, Becky, about smoking. If somebody changes from smoking to vaping, does that count as a stop smoking?
No.
So they have to stop completely?
I'll have to double check, because we've just set up a new service spec, but it's a good question, Andy. I'll have to take that away. to see in our new spec and with the definitions, but my initial reaction would be no, it doesn't.
Okay, because there were some papers from Public Health England about, although vaping, there's still some concerns about long-term risks. They still felt it was less of a risk than actual smoking. So that's why I was just wondering within the service spec whether it counts as a target, because then they're stopping the nicotine and the actual cigarette smoking. Whether you're on nicotine replacement, do you accept vaping as being an alternative to nicotine replacement?
Yeah, no, it's a good question. It's a good question. I will take that away and check the definition, because you're quite right. It's actually not smoking. Cigarettes is the definition. So if they're on NRT or vaping, then actually, yes, technically they have quit. Tracy might come in with with her knowledge.
I'm likely to add to the confusion more than anything else, because when vaping first came in, it was classed as a quit, but I think that has changed, and vaping was also referred to as nicotine replacement, but of course it isn't, because it's a nicotine product, so it's not classed as a nicotine replacement therapy. So this is why the specs have become so confusing about what counts as a quit. So because vaping doesn't include all the other rubbish that's in tobacco, so you haven't got the tar and you haven't got the other unhealthy aspects that clogs up the lungs, it's classed as a healthier way of taking on the nicotine, but you are still being exposed to the nicotine, which of course is the addictive bit. So you are replacing one addiction with, or one behaviour with another behaviour. That should use behaviour rather than addiction. But this is why it's such a murky thing, and it's really hard to find a really clear definition. It's been interpreted differently all over the place.
Yes, I mean, I've been trying to get an elderly diabetic to stop smoking for a long time, and whenever he comes into my room, or even he's handed me paperwork at the desk, because he's not allowed in my room anymore. He has to be seen in a separate room in our building for COVID infection control purposes. But even his paperwork reeks of tobacco, and it's awful. So the vaping wouldn't cause that. So I'm just sort of thinking, you know, where in the scheme of things is vaping acceptable or reverse as a quit? So anyway, then hopefully there might be some changes in perception.
Yeah, as a co-issue with diabetes, vaping would be by far the most preferable option to him than smoking cigarettes, for sure.
Exactly. Thank you.
I love the idea of his doctor smelling either him or the stuff that he's given him to see where he's at with the smoking quitting, which isn't obviously not going so well. Okay. Thanks very much for that. Is there any other? I think we've covered that. Thanks for the overview, and so it was really important information on that dashboard. In which case, with 2 minutes to 5, I think we're done, other than the date of the next meeting, which is the 18th of March 2022. So thank you very much, everyone, for those that have lasted through to the bitter end. And yeah, hopefully people can have a good weekend. And I'll see you all soon.
Thank you very much, Councillor Hoskin.
Thank you.
Bye.